Okay, can we get cracking, please? We've got quite a lot on the agenda today, I'm afraid. Paul Rue's got apologies from Paul Rue. Anna Bradley's going to be a little bit late. Everyone happy with the minutes? I think all the matters arising are picked up. So can we go straight to the Chief Executive's report? David, your report, please.
Good morning, everybody. David, thank you. So I've split this report into two parts, activity within CQC and activity within the wider health and care sector. So I'll do it at pace, David, because it's basically an updating report, and I think there's more substantive coverage of some of the issues that are flagged in the performance report, which is the next agenda item. But the first few items are updating in relation to the work on values, and importantly at paragraph 2 drawing out the challenge that we've got in relation to recruiting sufficient inspectors and analysts to actually carry out the programme of inspection activity that we've hitherto set out. I've gone into some detail about the work that we're doing across the organisation in relation to recruitment and some of the timelines in relation to bringing in additional inspectors and analysts. We've got a far more targeted and differentiated approach to recruitment now across NHS and particularly in relation to mental health to recruit inspectors. But this continues to be a challenge, and we continue to pay attention to that. Paragraph 3, I've flagged the progress in relation to the development of the academy. This work is developing well. Corporate inductions are now, I think, in the 10th phase of development, and the role-specific induction programmes for brand new inspectors is now beginning, and people are now on those courses. And indeed, I had an email at the beginning of this week from one of the people that was on the very first cohort who's now done her very first inspection by herself. So there's a sense that pipeline is now in place and beginning to deliver. And then later on, I draw attention to the fact that the regulations, this is in paragraph 8, have now been approved and will come on stream later this month, next week, and from the 1st of April. So the Academy will now provide the specific training in relation to the change regulations, the duty candour and the fit and proper person. It will hit in Mike's area from the 27th of November, then across all 3 inspection directorates from April of next year. So again, the training, the development of staff will be targeted on that. In terms of financial forecast, we, as a board, you asked me to update at the next meeting in relation to financial forecast, and at paragraph 4 I've set out what we project to be the year-end position, and that's in the 3rd bullet point at the bottom of page 3, which is projecting a £5.8 million underspend. That is absolutely related to the issues around recruiting inspectors, not due to any other reason. We've then got 3 updates from Mike's area, Andrea and Steve's area. I think they're self-explanatory in relation to it. I'll pull out 2 things, if I may, David. Firstly is the launch yesterday of the intelligent monitoring that Paul's directorate have done a huge amount of work on to get right, and Steve fronted yesterday. Some interesting impact to the launch of that. Chris Day, who fronted a lot of this work, and I thought did very, very well, sent me a note last night which just had some very interesting comparisons with last Tuesday and yesterday in terms of activity in our web pages. Last Tuesday, 52,000 people viewed our web pages. Yesterday, at about 10:30 last night, it was 279,000 people had viewed our web pages, so a 5-fold increase based on the activity that was around. What they then did is drilled into our website. So 46 people read the GP signposting information last Tuesday. Yesterday, 687 did. 37 people surfaced Steve's blog last Tuesday, and yesterday 316 people read it. So I think the point to make from this is the activity went up, but it also drew people further into our work. So I think a good example of how getting those messages out there can make a difference. Steve, do you want to just add any sentences?
Yeah, to play with the figures as well, about 1,400,000 of our pages were viewed yesterday on the CQC website, just to give big volume, and that's a lot. So I think yesterday's announcement is twofold. One is we also announced the first 2 outstanding GP surgeries, which are amazing surgeries in the Salford area of Manchester that work very closely with the hospital, which hasn't been rated yet, but is also a very good hospital. And one of those was a social enterprise, and the other was a small, high-quality, traditional sort of GP surgery. So it shows that small practices, when they work well with others, can do very, very well. The intelligent monitoring, though, I think is important because it does help us prioritise inspections, and without the inspections the model doesn't work. It's both together. That's been taken by some of the press about that it's ranking of GP surgeries, which it isn't. I think as a prioritisation tool it's been fantastic, and I think Paul's teams, particularly James Charles Evans and in the intelligent monitoring team, and also Chris Day, have done a great job. Thanks.
Anyone, any observations on the GP? Yeah, sorry, Camilla. Yeah.
Yeah, I mean, obviously one of the reasons we got more activity is it's quite controversial, isn't it? And the concern that people seem to have, some people seem to have, Steve, is that is whether we are properly weighting the different metrics that we're using. You know, whether we're putting too much weight on whether the receptionist is nice versus, you know, things that are more fundamental. Could you just, because I'm sorry, I've sort of lost track. I mean, are our key lines of inquiry now weighted, or are all our, I think it's 37 metrics, isn't it? Are they all equal? Are we taking them all equally?
No, we take them all equally for 2 purposes. One is that we want our inspectors to know if there's any aspect of care that we can pick up from the data. We don't think the data is comprehensive. We've said that throughout. There are some areas, particularly around safety and leadership, where it's less comprehensive. But it's important that our inspectors do know whether there's any particular issue, whether it is the receptionist being uncaring or the overuse of antibiotics, whatever it might be. And we take the same approach in all the sectors. We say at this stage we want to highlight levels of risk, and the way that we'll identify those bandings is on a straight aggregation of the risks, not on weighting individual metrics. I think we've talked about this a bit in the board. One of the things that we're doing with the 1 year on evaluation of intelligent monitoring is looking at whether we should do that, whether we should wait in future.
Yeah, I mean, I think I've had, I mean, obviously there's pushback for all sorts of reasons on this, which we know, and not all the reasons are good ones, but I have had some conversations with one person who was actually on an inspection, and I think there is just some concern, and we're in a very early phase of this, and we all know, as we've discussed before, we don't have information about the individual GPs, so we're rating the practice, not the GP, which I think is very unfortunate. We don't have the information from the GMC. Steve's talked about that before, which also I think is extremely unfortunate. But I do think it might be useful to sort of make clear to people, perhaps, that we will eventually move to a more sophisticated system. Do you know what I mean? Because I just worry that otherwise there's an impression out there that we care more about whether there are a few toys in the reception than whether people are safe. Do you know what I mean? Which isn't true, but do you know what I mean? I think there's a slight confusion about our metrics and how we use them, how they go into the eventual judgment.
I think we need to be clear, we don't weight the judgments. The data is not the judgment, as Steve was saying, even if people conflate it sometimes as it is. But when we do get to the judgment, each of the 5 domains, whether it's the caring domain or the safety domain, carry equal weight. So the reason I think for weighting individual metrics would be if we knew they were more predictive of risk in the system. That's one issue. But the fact that whether you can get an appointment or whether the receptionist is kind, would feed into or caring or responsive. That is as important in our judgment framework as safety and effectiveness, and we've debated that, and that's where we are as an organisation.
If I could add to that, David, the other problem we have when we look at the metrics is that the data that's collected is not as good as we would really like it to be, because unlike in hospitals, if you look at, for example, safety, the reporting of significant events or critical incidents, which should happen in general practice, doesn't happen consistently, and therefore it's very difficult then, because there aren't any tools at the moment to measure that. So when we looked into more detail at safety and effectiveness, there's quite a lot on effectiveness, but almost nothing on safety. And you'll see when we start to look at different ways of presenting this that it's a problem. And so you can go into a GP surgery and they've got very good systems in place on the inspection for safety, but it doesn't show you that on the data. So they're additive, both the data and the inspection. Where there is a really outstanding practice, and there's the two we've published, and there's one I visited 10 days ago, which is probably the best surgery I've ever been into anywhere in the world, for what it was specifically doing. That report will be ready around Christmas time. They have really good clinical leadership. The social enterprise had good clinical leadership, as well as the other practice. They have a learning culture. They learn from all of the incidents, and they share them with other practices in their locality. You can only pick that up on inspection. So it's a bit strange that some of the critics, and I share some concerns over the data, but it's transparent and it's out there, and people can make what they want out of it. As a prioritising tool, I think it's really good, but we can develop it. When you put the two together, you can then make a sensible rating on the practice. And of course, we don't rate if they haven't got patient groups in that practice. So the one practice I went to had 6 children on its practice list, and I think 9 people over 65. So clearly you're looking at a different set of people. And that's why our system, intelligent monitoring plus inspection, will give the population of England a much better view of general medical practice as a provider.
I guess beneath your question is the fact that the revalidation of doctors and the inspection of practices is the fundamental issue, isn't it? Which I think we all understand. It's just the way it is. Yeah. Okay. David, want to carry on?
Andrea's director continues to roll out the new wave of inspections, and the new rating system is now being applied. Andrea's, thank you, guys. Andrea's directorate roll out the new Wave 2 inspections, and the new ratings are now beginning to apply. So we'll see that work getting traction over the next few weeks and months, and will stimulate, I'm absolutely sure, a debate about quality and safety in relation to the care home sector in a different way than has been held hitherto. On intelligent monitoring, Paul Lelliot, who leads our work with Mike on mental health, tomorrow we publish the intelligent monitoring work that has been developed in relation to mental health, and again, is a significant development in our model, and the comments that Steve was making about the relationship between monitoring and inspection apply equally to mental health work as well. It's probably worth just drawing attention, David, to the events at the weekend in relation to Colchester, and the fact that we'd done an unannounced inspection into Colchester last week. A number of concerns were raised in relation to what we found in Colchester. There was public comment over the weekend in relation to this, and it's our intention to write to Colchester just to identify the concerns that we had in that follow-up inspection to our previous one. Colchester is a hospital that's already in special measures, And therefore, what we're signalling there is a requirement, having been in unannounced, that there is a requirement for more urgent action. But Mike's been leading this and had discussions with our staff and key partners as well. So,
very little to add at this stage. We went into Colchester. We do have concerns. The concerns have been widely reported in the media anyway. But as David said, we will be following this up with a letter just setting out our concerns to Colchester in the next day or two. We will keep a very close watch, and we're also working very closely with Monitor on this as the authority responsible actually for driving the improvement.
So you're going to be writing to them, but I mean, you fed back orally the concerns straight away.
Absolutely, yeah. As we always do at the end of an inspection, if there are any serious concerns, we immediately feed those back to the chief executive. We did that, but we are just following that up with putting it in writing as well.
And then lastly, David, and very briefly, I'm just flagging the fact I've already covered the regulations, but also that the 5-year forward view was published a couple of weeks ago now to a fair degree of publicity, and the debate is now shifting into how is this taken forward and how is it delivered. And it'd be wrong, I think, to bring a report to the board without mentioning the significance of that work. It had significant buy-in across the sector, and I think will shape up as a framework within which conversations will take place about the future design and development of healthcare services in England. And certainly I and other colleagues have been involved in some of those discussions. I'm also flagging, finally, the issue around hard truths. The government do intend imminently to publish a 1 year on from hard truths. That's, Robert, the government's response to your recommendations. And clearly, because a significant number of those recommendations related to CQC, then in the next few weeks there's going to be a narrative of progress against those recommendations, which will cover the things that, as a board, you have been working on with the rest of the organisation to make sure we can change the way that we inspect and regulate health and care services in this country. So I just want to draw attention to that. I've not seen any documents yet, this is something that is a government response. Clearly, I anticipate them referring to the work that we've been doing and the progress that we've made over that period of time, but it will be a position statement 1 year on. The significance of this, I guess, is there won't be another 1 year on before the election. So I think we're into that that space of actually just putting markers down around progress. But that's my report, David. Thanks.
Could I just go back to the adult social care issue? I guess it's a question for Andrea. I suppose I was struck by the enormous task that you've got, not for the first time, but so far, I know it's early days, but the numbers are frightening. Since the new inspection method came in, got a small number of reports. By my quick calculation, it's 48. And that compares to the target number, which is 25,000. I just want to get an idea of how long it's going to take us to get to the point where we've satisfactorily assessed the social care estate. So again, quick calculation, that's, so in the first month, so I know this is number of reports, so this is slightly unfair, but it's that's 1/500th of the actual number. So if you extrapolate that, that means it's roughly 40 years before we will get to the end of social care. So I just want to check whether there's some acceleration planned on that.
Thank you very much, Lewis, and for the entertaining way in which you put that question. I don't intend to be still doing this at the age of 90. Oh, indeed, 60. So there are two things to say. One is that we are increasing the number of inspections that we're doing. The first reports are coming out of the pilot that we did over the summer. We did, if the board members recall, we did 2 waves of pilots. The first we didn't rate because it really was the testing out of the new methodology and the rating structure. The second wave we did rate, and we're going through a process now that we have the powers to publish reports with ratings of validating those ratings to ensure that our published methodology is consistent with kind of the judgment that we came to and the ratings inspections that we conducted over the summer. We, as you'll pick up in the board report, performance report, sorry, our timeliness in getting reports out has dipped as a consequence of it being a new methodology, it taking longer, it being a very different way of producing reports. So we're not seeing, in terms of productivity, the numbers of reports coming out that are consistent with the numbers of inspections that are taking place. We're going through a variety of things at the moment to speed that up and unlock that, but we clearly need to make sure that what we're publishing are good quality reports and that people can rely upon them and that judgments within them are consistent across the country as far as we're able to do that. So our stated position is that we aim to rate all adult social care services by March 2016. That is, as you point out, 25,000 locations and is, I think, a tremendous ask of the organisation and of our inspectors. And one of the things that we have done this year, given that we have a very significant number of vacancies in adult social care, is to reduce the number of inspections, ratings inspections in Q3 and Q4. As part of our business planning, we will be assessing how quickly we think that we can get up to the required strength in numbers in terms of inspectors doing those inspections to be able to give the board assurance and the wider community as to whether March 2016 is achievable or not, or what is the achievable date. So I can absolutely assure you that it's not going to take 40 years.
I think, Lewis, we'll come back to the board with a revised timetable of how many we think we can do, probably after, maybe in early next year, when the new method, when it's all settled down, recruitment settled down.
So we need to constantly update you on recruitment. The purpose of me including recruitment in every chief exec's report is for exactly this reason. We've had previous discussion, and I think Audit and Corporate Governance Committee, this is flagged as the key risk. Money as the projected outturn is flagging is not the issue. The issue and the risk that we've got, can we recruit sufficient inspectors and then get them to the capability that we need them to? That's why the recruitment and academy paragraphs have been stuck together and will continue to feature. The business planning process will start, David, and we need then to look at how deliverable are those commitments we've made to complete all of this by 16, as Andrea has said, within the resources that we've got. We've currently got inspectors, and this is in the performance report, the next item, inspectors with caseloads around 45. We're flagging an alert around safeguarding and whether we're acting on all those, and this balance between people responding to what's coming in through the door in safeguarding alerts and doing the inspections and writing the new reports is really where the stress in the system is coming from. And therefore, the only thing you can flex is you can push the back end of the programme out. You can actually reduce the amount of time people are spending on things, or you can increase the number of staff. And I think our strategy is to try to do all three of those simultaneously. And that's what we're trying to say in the performance report. And I think that's where I'd anticipated exactly that debate behind the question you asked, Lewis, to be honest.
In that case, I wouldn't prolong it, but I suppose the other option is that we have another resource out there, which is the families of people who are in care homes. And at some point, I suspect we will have to talk about how we use them in a more, I don't mean that to sound as it does, but how we take advantage of their experience, their expertise in a more formal sense. So there is a sense sometimes that feedback from families is slightly soft information. We might just have to step that up a bit and look for ways in which they can feed in more formally to our system of ratings. I think that's the conversation we will eventually get to, because I suspect when we next discuss this, it will be about the non-feasibility of that deadline of 2016.
I wondered, in terms of shortening the process, I went on an adult social care inspection last week, and I'd like to pay tribute to the skill and sensitivity of the inspector in a not entirely easy situation, not least because I was there. But what struck me with the description she gave the care home manager as to the process to be followed in quality assurance, it struck me that a great deal of time was being, and I understand why, is being taken up with that, which delays the arrival of the report. And I just wondered whether that's an area which might be looked at without compromising, of course, the quality or fairness of what's done.
It's a very, very good point, Robert, and we are indeed doing that. I mean, I think that again, there are always balances in these things, and we, given the volume of the inspections that we're carrying out, we need also to make sure that the reports that are being produced and that people do rely upon. That's the kind of critical thing. People are using our information to make decisions about care for themselves and for their loved ones. So we need to make sure that it's right and proper. And we had a pretty rigorous quality control, quality assurance process through the pilots, and implementing that for the full rollout as well. But we have been looking to streamline that and also to share information with inspectors about what good looks like in terms of the types of report. We've also been working with the Academy around supporting better report writing skills and training for staff, and also looking at how we ensure that our inspection managers have an appropriate span of control so that they can provide much more proactive support to inspectors to do that. So there's a variety of things. I wouldn't like to say that we've cracked it yet. I think that wouldn't be right, and there are delays, and I'm worried about it. But we're working on how we can resolve that. And just to reassure Lewis, I mean, we are seeking to very proactively take into consideration the views of families and carers of people using services both in domiciliary care as well as in care homes, and that does form a significant part of the methodology.
Just to say whether we can squeeze in the space on the board to discuss the forward view in a little bit more detail, because it's such a significant document, and particularly the new models of care that it outlines and the relevance to us and our model. But also the hard truths too, that's also part of the picture. In particular, do you remember the gap we had with NHS England in our board-to-board and the board-to-board with Monitor was, what does the improvement architecture look like? What's our role in improvement? And I think given the review of the improvement anatomy and physiology in the system that's going on at the moment, I think a kind of discussion around what the response to hard truths is looking like and what's our role in all of that, I think would be quite, because I'm not thinking of a long discussion, but just something, a little bit of space.
Paul, could we, I think it's a good idea, maybe for the December board, could you and your team facilitate a discussion on both those, on the 5-year forward view and on the hard truths?
Yes, of course.
It'd be good to do that. We should do it in December. Yeah.
With a particular focus on improvement, I think that was one of the references as well. Yeah.
We can just, it's a short enough document just to circulate that and have views, but it's particularly the models of care and how we develop our model to kind of fit.
Paul.
And just endorse that about the 5-year forward view, because across the country, boards are having the discussions we've just had about the current business model and having to work really, really hard to make that business model work. And the forward view says we're going to have a new business model. And we could easily spend all the time discussing the problems we've got with the old business model. And the old business model is inspecting separate institutions. All 7 new models mess that up. And so we've signed up to a document, quite rightly, to say we're going to have new models of care which cut across our current business model. And at some stage, sort of in the new year, we're going to have to tell the NHS some ways in which that's going to happen, because otherwise people believe it's not really going to happen. If we go on reproducing, now we are going to go on reproducing for several years to come, and that's the right thing to do, but we also need to say at some stage we're going to be doing an inspection in a different way and we're publishing it this way. Otherwise, just having been at the Foundation Trust Network yesterday, people are sitting back saying, oh yeah, 5-year forward view, seen that before, we'll see this one off.
Steve. Thank you. To respond to Paul, so I have the lead responsibility for joined upness integration, and we're starting to look already at urgent care and how we might look at GP in and out of hours, A&E, 111 across a health economy. We're looking at joined up elderly care, which will involve social care as well, and there are interviews going on this week for clinical advisors to help us on both of those. And so we're also working with UCL partners and other areas that are putting new models in. So on one level it's so that we don't get in the way of new models, and on the other hand it's how do you encourage improvement within them. So we're already starting to look at that as part of what we're doing.
Is obviously critical, Paul. I mean, at the very least, we mustn't get in the way of new, better. But at the best, we must encourage it and support it.
I think all we need to do is actually say, publish this, what you're describing, and actually let people know that actually work is being done to do the new way of doing things, alongside the fact for several years to come we're going to roll out the previous ways of doing things, as will happen in the NHS.
I don't want to take time because this isn't the time to discuss it, but could we also factor, I don't want to be gloomy about this, but Hard Truths set some pretty challenging financial issues, which I think it's absolutely right should have been set. But we as an organisation may be required to deal with the aftermath of that not quite working out as intended, if I can put it politely. And can we possibly factor that into our considerations in terms of contingencies in relation to our future work?
In the impact on us directly, or on the impact on the institution we're looking at?
I mean the work we do.
Yeah.
The model, as I understand it, is conditioned on a radical change in the status of public health in this country in order to save the money which actually goes into what's then required. And that seems to me speculative, to say the least.
Well, there's quite a lot to get stuck into there.
There is. If I can take it away with the strategy team, the only thing I want to make sure it's a good session. I think we're only 3 or at most 4 weeks out from the December board, so we want to do a good product for you. If we can do it for December, we will, but otherwise we'll have to be early in the new year.
Right. Okay, thanks.
Can I just have one word on Paul's point? I was at the FTN as well, and my response to systems or institutions is to delete the or and insert an and. It's both, and I think Steve's point about inventing the future is the dementia report we did, which looked at the interface between care homes and hospitals and why people inappropriately end up in hospital because there's not community healthcare services to support people in care homes, is a really good example. Now, the interesting thing, at the FTN conference, I asked how many people had read the State of Care report, where we have as many examples of good and outstanding care as we do of poor care. So if part of our role is to describe what good looks like, I think less than 10% had read it. And we asked exactly the same question at the Health Service Journal conference last week. Andrea, Steve and I were there doing a session. and I think it was 15%. My view, a generous 15%. So I think there's a real issue here about how, when we are trying to comment on systems, there's almost an argument running that before we finish doing institutions, we need to start on systems. Actually, we need to do both. But actually, where we are commenting on systems, it'd be really helpful if we could actually get people to engage with those messages. Because otherwise, you end up in a shouting match, not a debate. Not a conversation about how we advance this. So I think there really is an important issue for us to grapple with here. But let me go on to the performance report. So there's a covering report, and then there's the standard new quarterly performance report, which is attached to Annex 1, Appendix 1, which goes into the detail. And I'm going to jump between the two in presenting it. Lewis's question about the programmes and our ambition to deliver the programmes and the relationship to the number of people that we are able to recruit into inspector and analyst posts, and the model, effectively, the resilience of the model we've got, is really what we are trying to draw out in this report, alongside two other issues. I don't want to gloss over the things which I think have gone well, where progress has been made. They're covered on the annex in slide 2, and we've touched on some of them today. The state of care report, the work on intelligent monitoring and primary medical services, the progress made in rolling out the new inspections, the progress of the academy, etc. I'd want to pay due attention and appreciation to the staff that have worked hard to secure those achievements. But what we're doing in this report, and this is really from paragraph 3 onwards, is flagging 3 issues which are of specific concern and are touched on in the report. And if I may, David, I'll address each one of those in turn. The first issue that we're flagging is on safeguarding, and at this point, if I could just introduce Sally Warren, who's sat on the front row. Sally, come and sit next to Steve, will you? Sally is Deputy Chief Inspector covering London, but is also responsible for our market oversight and in chairing the recently and newly constituted safeguarding committee that we've got within CQC. Sally is one of Andrea's team and has done a lot of work on safeguarding, and will over the past few weeks, and will do more in relation to this. So Sally, I think, can helpfully contribute to this debate. So what we're flagging on slides 15 and 16 in this document is a concern in relation to the activity responding to both safeguarding alerts and safeguarding concerns. An awful lot of work has been done on this data, and I think the conclusion that we are getting to is that this is a data issue rather than an issue that reflects as a lack of action which takes place when alerts and concerns come into the organisation. An alert is where the first agency receiving the safeguarding information, and we need to take some action. A concern is where that data will come into other organisations, and we may be the recipient of it alongside others, but the action is more than likely to be taken by that other organisation. But it is important intelligence to us. And you can see from the right-hand box on slide 15 that the black bar in the chart is indicating no action is taken. It is at that point, following audits and chasing this through with specific conversations with managers and inspectors, that the phenomena that is being highlighted here is the fact that people are not updating CRM, the database, when they've taken action. That isn't to say that there's not one or two places where action hasn't been taken, but in the numbers that are described here, that isn't what is being flagged. So that's what paragraph 3 in its detail is going on to highlight, and there's a record of some of the work that has been undertaken by colleagues to look at what's going on. A detailed audit has been carried out. Work has been undertaken to stabilise the position, and that's set out in paragraph 3.12. Specific conversations with inspection managers and managers. There has been work going on over the past few months, irrespective of this, to do an update on CRM, which for the first time will provide much more detailed information to inspection managers and heads of inspection. Hitherto, this information has been held at a national level and not at a local level, and this will allow managers to be much more proactive in terms of the work that they do with inspection teams on this issue. And intelligence colleagues have developed a new safeguarding dashboard which will provide information which will help inspectors better use current and historical information. And we'll also, before the end of the financial year, invite our internal audit colleagues in towards the end of the financial year to do a check that an audit that this work, this activity is indeed being embedded and improvements are taking place. And then finally, in paragraph 3.13, Sally, as I've already said, is going to chair the new safeguarding committee, which is the mechanism that we will have in place right across the organisation. This isn't just about adult social care, although this is where the volume of activity is, but this will go across primary medical services and across the hospitals directorate, is making sure that that committee is actually overseeing our work on safeguarding to ensure that the fragility that's flagged in this performance report is indeed being addressed across the organisation, and that committee will report into ET and will continue to report through these quarterly performance reports on our progress that is being made. Is it worth pausing at that point, David, rather than going into the other two areas? And
Sally, do you want to just comment at all, or do you want to just wait for questions? And
Happy to just wait for questions.
Okay.
Thanks very much. That's a helpful clarification. I must say I was slightly confused, but I didn't completely understand what the message was of this, although it was obviously a concern. I mean, I suppose the first thing is it would be really useful just to get an idea of the kind of incidents that we're referring to here, because safeguarding is quite a broad term. It covers quite a lot of things. It would be useful to know what are we talking about? What's the seriousness of these alerts? And then there's the slightly curious thing where the follow-up within 1 day figures. Obviously, the greatest number are in social care, but so is the greatest number of follow-ups, or proportion of follow-ups. And so there's a sort of sliding scale whereby the fewer alerts you receive, which the sector receives, the worse is the percentage follow-up. And so that needs some explanation, because that suggests it is something more than just the volume not being followed through on. In other words, the more you have, the better you do. That's a slightly counterintuitive capacity problem. And then I didn't completely follow, just to absolutely be sure that if this is a data issue, are we saying that if the data issue were to be satisfactorily addressed, we would be a lot nearer a target, which is a pretty high target of 95%, where the current figures are 48, 29 and 22%. So is that just a data issue? Now, excuse me if I've misunderstood some of what you're describing, but it is quite a complicated thing.
Want me to pick up on those, David? Yeah. Thank you very much, David. Very kind. So your first question about what kind of incidents are these? There is guidance about what issues are notifiable and which aren't, but this could be, for example, in adult social care, it could be unexplained bruising on a resident, which then would be issued as a safeguarding alert or a concern. So if the provider tells the local authority, we would be informed, and that would be a safeguarding concern. So we would know the local authority knew and was taking the appropriate action. If we're the first statutory body to know about a safeguarding issue, it becomes an alert to us, and we therefore need to make sure the right bodies are taking the right action. So it's that kind of issue around potentially bed sore, so high levels of level 4 bed sore, and unexplained bruising, etc. So that's the type
just
of
on that,
issue.
I'm slightly
Yeah.
struck by people from, say, the hospital sector contacting us with a safeguarding alert when those sort of things are found. Of course, I know that bruising might lead to so, but I'm just trying to get an idea of what is it people are ringing up and telling us. Is it, I mean, don't mean just, is it bruising, which is sort of what you'd expect? But this is a very particular action, and people in hospitals, people in primary care, ringing us up to make, it sounds like they're trying to tell us something more than just they found a bed sore.
So, particularly I think in hospitals and PMS, quite a lot of the safeguarding concerns we'll be getting will be children related. So Steve may well want to talk about that. But in adult social care, it's obviously working age adults and older people. So it's clearly there are different types of safeguarding issues for different types of client groups. And in hospitals and GPs, you also then have kind of clinical routes for being able to alert within the organisation, whereas there perhaps poor clinical care, that means it's not a safeguarding issue, it's a clinical issue. So, I mean, I'm quite happy to provide to the board some of the detailed information about what's notifiable and what isn't under the system.
I think, if I may, Lewis, I think your question is spot on, and I think Sally's answer is right to the heart of it, which is, I think there's a very expansive definition of safeguarding being used here, which will encroach onto clinical issues. So as well as the bruising, there may well be issues of we don't think there's sufficient staff on duty in a hospital. Question, is that a safeguarding issue or is that an organisation and management issue? And I think these are conflated. I know some of you, when you visited NCSC, sat in on some of the telephone calls. I know Michael has done this recently as well. And you listened to some of these stories as they were coming through and being triaged in NCSC. And I think one of the first things that Sally's going to do is look at this definition of safeguarding. I think we've now are in a position where we can do this. Now, the key issue for this is any definition we have will have a knock-on to other organisations, particularly the definition that local authorities as a lead agency in adult safeguarding are using. And the Care Act puts safeguarding boards under a statutory responsibility to local authorities when it was passed. Again, just realising the full significance of what the Care Act was actually doing. It wasn't just about hospitals, it was about some pretty fundamental issues around social care which have almost been drowned out by the other noise. But I think this is absolutely critical that we're clear about what is a genuine safeguarding issue and what is an issue of poor clinical care or poor management and poor leadership of an organisation, and not conflating these into a homogeneous category which actually just puts everything together, and because the action that's required is going to be very, very different.
Just a quick question. For those cases for which there has been no action and they have not been included in an audit, what do we know is in there? Could there be something very serious? Is there some initial triage that we've done on all cases, even if we haven't audited them all?
So we have done for all of the alerts with no action, we have done an audit for them. For the concerns, because the numbers are much higher, we're going to struggle to be able to do an audit of all 4,000 cases, but we're going to audit a sample of those so we can start to understand, is it the same issues affecting concerns as affecting alerts, and therefore it is the action has been taken but it's not recorded, or is there a different set of issues within concerns? But to answer your triage question, that we do just have it's an alert and a concern, and within the concerns then the inspector, when they receive the concern, would then be making a judgment themselves about the type of action. So we don't have within the concerns a further set of kind of triaging of. We've been able to audit all of the alerts, yeah.
And I think just to say there's also a definition issue on the concerns as well that we're picking up in terms of what's being recorded as a concern and they're not followed up. I mean, includes things like invitations to safeguarding meetings, and so which isn't a concern. So but it's safeguarding, and it needs to be shared with inspectors, and that's appropriate. But I think that there is something, and this is part of the work that Sally's group and extending with colleagues across the organisation will do, is make sure that we're much clearer about how we define what comes through, and then what action it is that we're expecting inspectors to take.
It's really the definitional issue what little I know about it suggests that safeguarding is all things to all people in terms of a definition. I think would, however, caution on doing anything which persuades people not to report things because they're not. We or somebody else has said they're not really safeguarding. Would be the first point. And I just wonder whether, if it is a really broad definition, whether the answer is perhaps to look at the target and whether that's too demanding. And what we ought to be looking at is whether there is a better way of immediately triaging what comes in terms of its seriousness, whether it be an alert or a concern. Because it would seem to me that, for instance, some concerns which are said to be dealt with by someone that comes from another organisation, it might be really serious, and actually particularly so because the organisation might have reported it to us and be doing absolutely nothing about it. So there's a judgment, I would suggest, which could actually mean that we concentrate on the serious ones before we get to the less serious ones.
Robert, a really good point. I completely agree. So part of the work we agreed yesterday at the Safeguarding Committee was that we want to look at both our systems and processes to make sure that we are that we understand the end-to-end process and are streamlining at every point to mean the riskiest information is getting to our inspectors quickest, and we're acting on that. And also to think about the information and intelligence we have, and as part of that, to think about, is the KPI the right KPI? We've got one KPI for alerts, one for concerns. Actually, if we were to start to triage them slightly differently, would we start to get to the point of having maybe 3 or 4 different categories with 3 or 4 different KPIs? So absolutely the kind of issue we want to grapple with through the work we're leading on the improvement.
And also just to reassure you, Robert, I mean, this is kind of our internal processes and how we manage things, rather than giving a subliminal message to people externally that they shouldn't be sharing their information with us. I mean, I think that we are very clear that through all of the efforts that the engagement team does in highlighting to people that we do want to hear from them, hear from their concerns, and feed that through. So I think, apart from watching this board meeting and seeing us have those discussions, what we're trying to do internally is not going to, I hope, damage that message out to other people.
I was just going to say that that this is also linked to whistleblowing, and just sort of hearing about the different definitions about what is and isn't whistleblowing. And the fact that some of the concerns are related to, the organisation, the management, the leadership of an organisation, rather than a very specific incident. And I just wondered if that was kind of linked in with your work, and to what extent. Yeah.
Thank you, Kay. A really important question. So I think there's 2 aspects to the link. So you're absolutely right that quite often the same issue can be prompting a safeguarding alert, a concern, or a whistleblowing, and potentially a complaint. And that's actually what's driving some of the data quality issues, is our inspectors are updating one bit of CRM but not updating the kind of 3 different records all relating to that issue. So there is a kind of, it exacerbates our data quality issue. But on the more substantive point, there is a programme of work being led by Eileen's team on improving the customer experience of providing us with information and intelligence. And we've linked very closely the safeguarding work with that work. So Caroline, as part of our safeguarding committee, is leading that work, and we'll make sure particularly the kind of system end-to-end analysis is joint with the customer experience work. So we're coming up with one way for people to provide information, and for us to ensure that it goes as fast as it can to the right people to make the judgment about it.
And also, I think, closing the circle, because quite often I hear people say, I reported something, but I don't know what happened, or I didn't hear anything,
Yes, absolutely.
And
yeah.
I think that's partly to do with defining what they're reporting or what we're doing with it. So it's about sort of closing
Yes.
the loop, so people are clear how we've responded, what we're going to do, what we're not going to do, maybe. You know?
Absolutely, and that closing the loop is an important part of Caroline's work on the customer experience, because it does make the experience poorer if you feel that you've just put something into a black hole. So even if we've acted appropriately on it and we maybe brought forward an inspection, we've taken enforcement action, if you don't know that we've done it, it can feel quite unsatisfactory.
Sorry, I'm not sure we got a reply to the second bit of my question, which was about just a data quality issue. And once you factor that in, are we nearly at 95%?
Yeah, I thought I'd managed to get away from that question. We would definitely be much closer, but I think I couldn't honestly say to you we'd be at 95%, and that partly links to Robert's question that it's a very tough KPI, and is it necessary for a lot of, particularly in the concerns, for the KPI to be that tough? So I think we'd want to be going to a point of having a bit more of a sophisticated set of KPIs. But I could give you assurance we would be much, much closer to the 95. I just don't think that we would be at it, even with the data quality issues.
When will you know? When will you know how we are doing in substance? When will you clean up the data, if you like?
So we're hoping to have concluded the audit on the concerns by the time we'll be reporting to you on Q3, and we also would have hoped that our work to try and stabilise the position would have started to feed through to the data. So by Q3 we should have a much better understanding of where our kind of immediate action to stabilise performance has had. Obviously quite a lot of the improvement programme that the committee was talking about yesterday is quite long term. It's not going to be an overnight improvement if we're trying to think about how we realign our systems. So it's a bit of a two-pronged approach of what can we do quickly to stabilise the position and make sure we're responding in a timely way in the organisation to risk, and what can we do in the long run to be much better and smoother at that.
Okay. Sorry, Paul, then Michael.
I mean, given what we do with other organisations, we're never in a position to put the word just in front of data issues. Because actually, if a thing isn't recorded, it hasn't happened. Now, that's what we say to other organisations. And actually, other organisations come back and say, no, we've looked at the series, we've done all the good, but we just couldn't be bothered. We couldn't. So actually, recording things is not a just issue. It's got, otherwise people will point this out to us quite vociferously when we insist they have good data.
Good point, Paul. Yeah. Michael?
Yes, another small point about safeguarding. In David's weekly update to the board, there was a section on Colchester, as Mike will know. It actually says, and this I got very confused about who's doing what here, but it may not be a problem, but it says the safeguarding authority has been contacted on investigating safeguarding concerns on 3 patients. I just wondered who were these safeguarding authorities, and why did the CQC? Well, I'm not saying the CQC shouldn't have raised this with whoever the safeguarding authorities were, but I just wondered what was really going on here and what we meant by safeguarding in this particular situation.
Shall I start that, Mike, and you might want to come in? So safeguarding authority in that sense is the local authority is the lead local statutory body for safeguarding. So any safeguarding instance is the hospital in that case would be reporting to the local authority, and they then investigate, and there's different levels of investigation depending on the seriousness of the safeguarding issue. So in that scenario, to show the difference between an alert and a concern, if the hospital had told the local authority and then were informing us that they've told the local authority, that becomes a concern for us. But if we were the first person the hospital told, it would have been an alert, because we would have needed to act much sooner, inform the local authority, potentially the police, depending on the safeguarding incident. So that's the kind of difference. In the vast majority of cases, as you can see by the numbers, the information is normally given to another local statutory body first, who take the immediate action to assess the level of risk to the individual and mitigate that risk. And we're being told, so we can have a whole picture of what is going on in that service, so we can assess, do we need to go in sooner, do we need to do an urgent inspection, bring forward a planned inspection, etc. can I just briefly comment on Paul's point as well about data, because I think it's absolutely right, and it's a conversation we've had at the exec team as well, that it isn't good enough just to say, oh, it's just a data problem. I think what we were really keen to understand when we first saw the level of performance was we needed to understand, was this potentially a performance issue that meant that people were being exposed to a level of risk by our inaction. So our first question to ourselves was, what does this mean in terms of risk to individuals? I think through the audit we've been able to assure ourselves that we are responding in a timely way about risk to individuals. We're not recording it properly. That isn't something that's satisfactory in an organisation that has the aspirations that we do. So we now want to be putting this programme of work in to make sure that we do start to record properly with the current system and look to improve the system. So I can reassure you we're not being complacent about a recording issue, because you're absolutely right. The organisations we inspect, we wouldn't tolerate that from either.
Michael, did you want to pursue your question, or is that all right? Yeah, okay.
I was just interested in the fact that we did an inspection, and then I just wondered who this safeguarding authority was. I didn't realise that local authorities have a safeguarding responsibility for hospitals.
So just to add to that, local authorities have a safeguarding responsibility for all adults that live in that geographical area. And that could be whether it's a service they're receiving in a hospital, in the community, or indeed visiting the church luncheon club, i.e. non-statutory services. And this morning we've got the Ofsted report in relation to local authorities' performance in relation to children's services. The Care Act introduced a similar statutory responsibility for local authorities in relation to all adults. And that was the equivalence point that the government responded to over the debates over the past 3 years by placing adult safeguarding on a similar statutory footing. Until that point in time, the local authority responsibilities were voluntary. You were encouraged to do this. It's now a statutory requirement, and as Sally was saying, what this means, Michael, is for the bruises where that might have been as a result of a deliberate harm that was perpetrated by a member of staff, wherever, there will be a safeguarding investigation that's required. We still have responsibilities, but there'll also be a police investigation running alongside that. So theoretically, you could have 3 investigations running alongside each other. So the issue of the definition, to go back to Lewis's very first question, is absolutely critical about what do we do, what do the police do, what do local authorities do, what needs to be done together, and what is done separately is really about the choreography that's required at a local level. And it's very, very difficult because unlike children's safeguarding, I personally would argue that the money's not been invested in adult safeguarding in the same way. And therefore what we're doing is a system which is not yet mature, but has a significant number of referrals being made into it, which actually need to be investigated by all 3 agencies. And so that's what the Safeguarding Authority makes. Maybe I need to be clearer in the reports that come to you on Friday about just naming what the Safeguarding Authority is. But publication of reports. There is an issue about the delay in relation to new inspection reports. It's already been flagged earlier in the conversation on the back of my report. I'm not going to dwell on this, David. We're just setting out here what our current performance is and what is being done about it. I think Robert's question earlier and Andrea's answer to that goes to the heart of specifically some of the actions, looking at our systems and processes and how we strike the balance between consistency and efficiency in relation to producing those reports. We've had previous discussions about the quality of our reports, the English that's used, the accessibility of the reports, and these are the issues which are being grappled with at the present time. But the truth is, as these figures demonstrate, the number of reports being published within the given timescale, the performance indicator, is not meeting that target, and we are taking action on this. I think we will, over this next period, review whether that target is too tight or not tight enough, and we'll continue to report and update you on that. I'll pause at this point, David, in case anybody wants to come back on this.
I think there is a general feeling that a lot more of the reports could be sort of drop down or a drop down menu for people, because there's, the number of inspections I've been at, people do find it hard to write these reports. Quite a lot of the report is very similar from one inspection to the next, to the extent to which we can get more commonality through a common template. I know you're looking at that, Andrea. You're looking at me, sort of slightly.
not quite horrified, but there's a balance here between the fact that actually we do want to support consistency and enable inspectors to write reports which are useful for the public. So I think the things that we've done around being clear about the key lines of inquiry, what evidence goes into what section, and what the characteristics of the ratings are, and how that should be reflected in the areas. But absolutely, we should be reporting on what we have seen in the inspection, and that cannot be plagiarised or cut and pasted from drop-down menus or from other people's reports. Particularly as a significant element of what we do when we're on inspection is talk to staff and talk to people who are using services and their carers and families. And if we're reflecting that, we need to be reflecting that in an accurate way. So I kind of get the point, but I also need to make sure that these are authentic reports that are reflecting what's actually happening and what we've seen. And it may well be that from an adult social care point of view, because our intelligent monitoring and data ahead of an inspection is not as extensive as it would be, say, for one of Mike's inspections, I may therefore feel a little bit more strongly about that in terms of not pre-populating reports before we've actually done the inspection. So, but nevertheless, I completely take the point that we've got to be quicker.
Thanks. I think things are slightly different when you're going into a GP surgery. So there's only a certain number of ways of writing the medicines management is safe in an ordinary surgery, and the fridges are monitored. So we're experimenting with a limited template for the specialist advisors and the rest of the team. I used it 10 days ago, 2 weeks ago now, and it cut down the amount of writing I had to do, although I still wrote 19 sides of A4 notes because it was such a fantastic practice. These were examples of above and beyond what you'd expect. But the template cut down the work, and it will mean that the inspector who writes the report, it will save them a lot of time, and the feedback so far has been very positive. But it's different to social care.
I'm sorry. And the last item, which we've already touched on, is the issue about recruitment of inspectors and the relationship to the delivery of the programme. And I think this has slightly more granular detail in relation to Lewis's question on my report earlier. So, what's the issue for inspectors? Well, inspections are taking longer because it's a more thorough, more detailed methodology that allows us to, in quote, get under the skin of organisations, unquote. The makeup of the teams is greater. Instead of, in adult social care, one person going out and looking at a care home, there's likely to be 2 or 3, an expert by experience and perhaps somebody that brings other expertise alongside an inspector. And in some of the very big care home inspections, there could be 3, 4 or 5 inspectors plus those additions. Mike's teams have up to 10 inspectors plus experts by experience plus clinical experts, and Steve's teams have a inspector plus a GP plus an expert by experience in most cases, although not in all cases an expert by experience. So there's more people, and the point that we've just touched on, the reports are taking longer to write, but also the number of concerns that are coming through that inspectors have got to deal with are also greater than was originally anticipated. The original modelling for the number of inspectors had assumptions in there that inspectors would spend 70% of their time on inspection activity and 30% of their time on related activity, responding to concerns, etc. We revised that in July in the report we brought to the board in July. So that, particularly in Andrea's area, adult social care, we changed those assumptions to 60% on inspection and 40% dealing with alerts and concerns. And the data that we've just looked at in relation to safeguarding alerts and concerns drove that rebalancing. The consequence of that is inspections are taking longer and there's more work for inspectors to do in responding to alerts. We've not been able to recruit at the rate that we assumed, and we've spoken about that here on previous board meetings. So what we're setting out in paragraph 5.2, we've done some further work on this over the past couple of weeks in preparation for this meeting, but also just in terms of our own management of the organisation, that we need to deliver over 7,000 rating inspections across Q3 and Q4. To achieve this, we'd require 958 inspectors in place for October and 993 for December, where currently we've got 810 inspectors who are in post and available. So we've got a shortfall. That's particularly acute in hospitals and particularly within the Hospitals Directorate in mental health. Also in medical services in London and in adult social care, particularly problems in the central region. So there is a recruitment plan in place. I covered some detail of that in the earlier report. And our ability to deliver the agreed ratings commitments for this year, 14-15, will continue to be reviewed. But at the minute, we're working on the assumption that those over 7,000 inspections will be completed by the year end with those inspections. This is what this report is flagging. Lewis asked a question about what does this mean for 15-16, and actually we're not commenting on 15 and 16 in this report. That work will be done as part of the business planning process, which we've now begun, and that will come to the board, David, for an early look in January, and again back to the board for final agreement in March of this year. So that's the plan, but what we wanted to do is flag this. I think to Paul's earlier point, all three of these items are, if we were going into other organisations, we'd be having a conversation with them about, do you know what your problems are? Have you declared them? And are you taking action on them? So what we're trying to do here is model what we would expect others to do to play to the question that you asked. I think the first thing you do when you find out when there's something not quite right from the figures, you find out what's behind it. Second thing you do is you stop it getting worse. Third thing you do is improve it. So I think what we're trying to model here is exactly that approach to these three areas of risk, and do that in a public way at a public board meeting. And Sally referred to the conversation we had the executive team, and the very words that you used were uttered on more than one occasion. If we were going into somewhere else, what would we say? If it isn't recorded, we'd say it's not been done. And I think the challenge is absolutely spot on. But what we're trying to do here is just actually be absolutely clear about where we are and what this means. So I hope that helps, David. But
any just before we move on, any just general comments about this new reporting quarterly performance report? People, broadly speaking, think it's happy with it? Look.
Are we allowed to comment on the content of it?
No, you can, yeah, do, yes.
I find this report incredibly interesting. In fact, it's almost too full in a way of things. I mean, it's very, very, very helpful. I've got a question about one item. It's just to illustrate how full it is. Was one of the issues that you haven't raised, David, is this question of how long it is before we take effective action against non-compliant locations. And that does worry me a little bit, because obviously they are non-compliant in something presumably important. And so that matters to the people who are getting that service. So this is in relation to page 19 of the report. But of course, it's also about public credibility, and does it make any difference if we say you're non-compliant? Because if you don't do anything about it, does that really, what has been achieved? And so on that page, it's very striking that there are almost 1,000 locations where people have been non-compliant for over a year, and a quarter of them they've been non-compliant for over 2 years. So this does, for me, raise a very important issue about how we follow up what we find and what we require of people, and what it means for CQC to say that something is not right about your service if you can then go over 2 years without actually putting it right, or for that matter, letting something else go wrong that you then don't put right. And this issue of public credibility is very important. We're going to talk about public engagement later, I think, but I suppose I imagine that what the public really want to see from CQC is that when we intervene in some way, that things happen and there is improvement and change. And I guess that is generally true, but this is a substantial number of cases where it doesn't appear to be true. So I just want to get your comments. A lot of them are in social care, of course, but I'm afraid, Andrew.
If I go first and Andrea can come in. So you're right, Lewis. We did cover it in 2.6 and 2.7 and drew it out in the covering report here about this. It's an issue that we've discussed here previously. So I wasn't trying to not pay attention to it, and maybe I glossed over the beginning to get onto the three big areas. But in 2.6, again, we've gone through this in some detail at the executive team. I think we've got more work to do on this. I don't think we've bottomed this by any stretch of the imagination. It's not unrelated to the issue about the resource capacity that we've got to do this work. I'm not offering that in any way of excuse, but by way of explanation. I think what we've tried to do in 2.6 is the analyst colleagues have done some work on this, which is saying, although we've done fewer enforcement actions, as a ratio per inspections completed, we've actually taken more enforcement action, and that's a point we're making in 2.6. I think in 2.7, Steve's teams have done quite a bit of work on non-compliance by location, and that is showing some improvement and reduction in this. But you're right, it is an issue that we continue to attend to, and it plays absolutely to the point about credibility and trust, which is actually so critical to our work. So I wouldn't want to give any impression that we don't think this is a significant issue. At all, it is. But do you want to add, Andrea?
Thank you, yes. And I think that identifying it in this way doesn't mean that we're not taking any action, because we are taking action in terms of both judging people as non-compliant and making that clear and that information is available. In a number of these locations, we will have undertaken warning notices. Some of them we have, because we've reviewed these figures, these are to the end of September, some of them we have scheduled rating inspections and are going back in. Some places are getting back into compliance, but others continue to have problems, and sometimes it's kind of shifting between different areas. A number of enforcement actions have taken place, and some have been deregistered by themselves and have fallen out. It's one of the reasons why we're looking at special measures in adult social care, because the way that we have been working up till now, we haven't necessarily been absolutely clear about what the end point is. So you may well have been non-compliant, and we've kind of gone back and either people have kind of improved in one area and not improved in another, or they've moved from a moderate level of impact to a minor, and you can see that they're on a trajectory. But what we've not done is then said, well, if the next time we come back and it's still a problem, then we are going to deregister you and you won't be able to provide the service. That is what special measures will help us to do in terms of being clear about those timescales. So I think that will have an added benefit in terms of what we're doing.
But presume the red part of the bar could underestimate our impact, because it could be that we have taken action against poor standards in some areas and they have improved, but actually they've dipped somewhere else. So in a sense, that red could underestimate our impact, although truly overall they're non-compliant, but actually our targeted intervention has been effective. So I think it would be useful to know that. I don't know.
Yeah, so we look quite some detail underneath these figures, and that's exactly what happens. So for the ones who have been non-compliant for more than 12 months, have typically been non-compliant on 5, 6, 7, 8 outcomes at different times. So there is absolutely that sense of trying to get on top of one issue and another one pops up. There's also something in these numbers, if you look particularly on the adult social care and in primary medical services, about where the improvements have come tends to be in the middle, there's lighter green and the yellow. So where it's a bit, you might hypothesise that there is a group of providers who we're particularly able to act on. They've been compliant for some time, but not a great deal of time, and we're actually able to reduce the numbers in those bands. But there's a separate group, and this gets to Andrea's special measures point, who appear to be incapable of coming out of non-compliance, whether it's on the individual issue or they're just moving between a series of different outcomes. And that's why special measures across all the sectors is so important, because it gives a time-limited opportunity to improve. Otherwise, we're saying quite clearly, and we're discussing this at the board in public in December, there has to be a clear endpoint at the cancellation of the registration.
And I think the other thing that's actually also going to help us is rating the 5 key questions and showing those as inadequate through to outstanding, but specifically looking at well-led on this, because it's that sort of that inability to have consistency and sustainability around addressing problems, which I think our focus on the well-led question will help us to pull out and help us to identify what action it is that organisations need to take. So I think that there are many aspects of the new approach that will hopefully drive the improvement that we all want to see for the people who are using all of these services.
Thank you. Oh, Robert, yeah.
Answer to your invitation, really, but 2 points in one, and it's about bullying, but particularly what's at page 22 and 23 of the report. And it sort of plays into what we expect of others, we should expect of ourselves. It is said that bullying, 12% stated they've been personally bullied or harassed at work, and that's gone down, 2%, which I hope we don't regard as a virtue. 21% of staff have reported they've witnessed bullying and harassment. And really what I would suggest is, firstly, I'm sure we'd all agree that's in itself not acceptable, whatever one might say about benchmarks, because not only is it unacceptable in itself, but it almost certainly means that the staff are not doing who are being bullied are not doing their jobs properly or capable of doing them, and are not raising concerns, for instance, when they should be. And I just wonder whether some more granular work could be done about that, and so there's a focus on it, because it's essentially what's being said here by this number of staff, and we're talking hundreds of people, if you extrapolate the figures, is that they're witnessing or experiencing unacceptable behaviour, and what I'd like to know is what's being done about it, and I'm sure most other people would as well. So, and when we see there are happily, in one sense, very few disciplinary cases, none of which, as far as I can see, relate to bullying. Is there therefore some discordance there that we need to be looking at? And then finally on that page, at a slightly different point, there's a reference to internal whistleblowing, which I, of course, have a somewhat current interest in. No figures are given there, but I imagine, I infer from that that's because there haven't been any. But I do slightly question why whistleblowing is included in a section about discipline, because if that's what it is, because it gives, I just don't understand why it's there rather than under some form of governance or procedure. And it doesn't look to me that the message has been given that we would encourage our employees to whistleblow if that's what's required to put something right in our organisation.
We can look at the presentation, going backwards through those, we can look at the presentation of this just to actually detach that point and not make that connection. I don't think it's intended to make that connection, but we can just make sure that we disconnect it and then it's we don't invite people to do that. On the issue, no, the levels aren't acceptable, Robert. Yeah, that's absolutely right. And the history of this, going back into 2012, is when I came into post, I got lots of emails from members of staff who felt that uncomfortable with bullying and harassment. And the figures were well into the 20% on experiencing it. We commissioned an independent piece of work by a person called Sarah Hunter, who came in and spoke to many, many people, ran confidential sessions with individual members of staff, and that drew a report together which highlighted this issue. And that report was published about 18 months ago now, I think. Maybe not 18 months ago, maybe 14, 15 months. Sarah was in earlier in the year and actually repeated that study and spoke to more people in relation to it. There was a sense from her report that some improvements have been made, but there is this issue that still needs to be addressed. It's still a feature of the organisation. I think this material is drawn from the July staff survey, and work is going on across the organisation in teams about what action can be taken in relation to bullying and harassment. We introduced dignity advisors. These were local people. Bullying and harassment, dignity at work advisors, I think was the title we called. These were go-to people if people didn't feel they could go to their manager. I think in the staff survey, we asked the question, do you know who to go to if you are concerned about bullying and harassment? I just can't remember the figure, but the return is something like very high 80s or very low 90s of people know what the procedure is and who to go to. I think what this flags, though, is if you know the procedure and you've either experienced it or witnessed it, why don't you use that process? So I think that's the issue that we're trying to address. So it's a different conversation that's taking place about where we go next. Just last weekend, I had an email from somebody who's now resigned from the organisation, who went into a long explanation, because I invited them to, about how they felt that they weren't valued and felt that they'd been bullied by their manager to deliver their programme, and felt they'd not been rewarded to the level they thought they should have been. And they were unambiguously clear that this was bullying. I said I'd pursue this. The person that they say had bullied them had now left the organisation, and they wanted to alert me to it rather than do something about it. I think that's endemic of the kind of permafrost around this issue, about people will talk about it and it will come out in confidential surveys, but when it comes to actually raising it, it's become very, very difficult to do. And as I say, I think the organisation is under immense pressure at the minute, and the degree of skill that we're asking of managers to set the pace. I'm confronted by this on a daily basis. How do I say we need to get our reports out on time, deliver this report to target in a way that is not going to stray into saying being unreasonable? Somebody's unreasonable, is somebody else forcing the pace? This is a really tricky set of issues, but I think we've still got too much. And therefore, I think the work we've been doing on the back of the staff survey, the work we've been doing on values really does allow a different conversation to take place about what do we need to do. Helen McNamara, who's been doing all the leadership development work, I'm due to meet with, I think it's next week, about the preliminary thinking she's been doing on what is the management development we need to do. And I think a feature of our management development programme going forward is how we address these issues of how can you set the pace but in a way that supports the staff. So I think it is something we do take seriously, Robert. There is a history to this, but those figures are still too high. When we presented the staff survey, I said there's some good news here, but actually I think I said at the board I was disappointed that we'd not made more progress based on last year's survey, and this was one of the reasons that I was disappointed that we'd not made as much progress as we can. So I think we together as an organisation need to respond to these issues.
Mike, you always say that one of the key statistics you look at when you're inspecting a hospital is this issue.
I do indeed. It is worth just noting in the hospital sector, the average from the NHS staff survey is 21%, so it is considerably higher than we have here, but not that denies anything that David's just said, but it's the variation that we see within hospitals that is alarming, and so we do particularly look at the ones with very high bullying rates, and as you may know, we're moving on from there also to look at it, but by particular staff groups, and particularly what the rates are within BME staff groups.
I mean, obviously, our staff are under a great pressure. They're working really hard, and they are doing a good job, but they're sort of at the same time being asked to do more, which obviously leads people to feel they're not being valued. And also I've heard staff say that they don't feel supported. I'm not quite sure what, support can mean all sorts of things, but I just sort of, if I said, how are we supporting our staff and how are we valuing our staff? Are there things that we could do to actually, be clear that we do value what staff are doing, but also think about how, what support could look like. I don't know if they have the opportunity for like supervision or reflection or, I'm not quite sure what it is, but, if staff are saying, I don't feel supported, then maybe we just need to look at a few kind of intervention strategies to actually help staff feel more supported. I mean, I don't know if that's a bit naive, but if they're saying that, then, sometimes it's just about being able to talk to someone or, it could be quite simple things. And, allowing that to happen might actually make a kind of bigger impact.
It's not naive at all, Kay. I think how does an organisation get to being excellent? And it's by small marginal improvements. It's not by doing one big thing. And I think making sure one-to-ones are taking place, making sure that team meetings are taking place. As small examples, I'm currently doing open door sessions. I did one in Leeds and Newcastle last month, and I'm in Birmingham next week, where I've just cleared a day. And this is on the back of the staff survey of people saying they're not listened to, cleared a day, put our appointments in and said anybody can book to come and see me. The interesting thing about this is lots of managers are coming to see me. Hitherto, people think my Friday message is just to inspectors, not to managers. Now managers are coming, but a very small example of just a little thing that can be done. A manager came to see me in Newcastle. She was quite upset. And felt she wasn't coping, but was determined that she was going to stay with a job, that she wasn't going to let the job beat her. Fantastic demonstration of commitment and resilience, I have to say. She said, why can't I have, when I'm doing a quality summit, I've got my laptop open, working remotely on the end of a telephone, and I can't hold the provider guidance in front of me and open the report at the same time on a laptop. Why can't I have a paper copy of the provider guidance that I'll take to me to every meeting I go to? So I said, I haven't got a clue, but let me take that away and we'll sort that out. We came back, had a conversation with Steve, and she sent me an email on Saturday. There's a clue in when they get these emails. But anyway, she sent me an email on Saturday saying, I didn't say thank you. I've now got my paper provider guidance and it makes a difference. So these little things, I think, are about making a difference. But I think the other thing which is becoming clear to me. This is a hypothesis, Kate, rather than people. Stress comes in work. I know I'm more stressed in work when I feel the job is controlling me and I'm not controlling the job. And I think we've got a whole bunch of inspectors who feel the job is controlling them at the minute. So what is happening is they're not having things like team meetings where they come together. A group of 4 inspectors from across West Yorkshire and Humberside came to see me in Leeds and said, we don't have team meetings. I said, why? They said, we haven't got time. I said, you can't not have time to come together to have your meeting about how you are working together. Not about what briefings are coming from me to others, but actually just how you reflect on your practice and have a conversation about how you support each other. And I think we just need to keep emphasising this is about doing the simple things well and saying it is absolutely right and proper that you have your team meetings and you spend some time together, whether you, please don't book an expensive hotel, use community facilities, take a place in a town hall or in a health centre or somewhere else, but take the time out. And I think the issue about the conversation why we need to revise some of our key performance indicators, if people feel it's a team meeting for support that's being squeezed because they're chasing a report out, to be honest, I think I'd be okay with a report going out after 61 days if they had a day to have their team meeting and they travelled to it. Remember, this is, they're all working in their own homes, they're all working in isolation. The only time they're going to come together is for these team meetings. So I think you are right, it isn't naive. We do need to do these simple things well. And we know from the staff survey, to go back to Robert's question, that actually not all one-to-ones are taking place and not all people are having team meetings. The other thing from the staff survey, the top 3 things for morale was access to training was the top issue. And which is why the academy issue is so important, making sure that that offer's coming through to make sure that people do feel supported by it. So we just need to keep going, Kay, and keep asking people, how is it for you, and keep responding to what people keep coming back to us. People, one person said to me, I told my family it would be better by July. They then said, I'm telling them it will be better by Christmas, but on our recruitment figures, it won't be better by Christmas. It won't be better until the end of next year. And I think we just need to be very, very straight with people that there aren't a bunch of reinforcements coming over the hill tomorrow. If we're going to recruit the people we need, then it will take us time. And that's not because people aren't doing anything. It's just because it will take time to recruit people and get them ready to go. So I think balancing work and resources is the key thing for us to do.
Look, we've got to get on, I think, but Eileen, you had one last point.
Yes, it's just one short, very short last point, which is on whistleblowing, Robert. To reassure you, it's not treated in any way as a disciplinary matter in the way it's presented inside the organisation, and no, we have no live whistleblowing instances at the moment. Okay.
Sure. So the next item is the knowledge and information strategy, the intelligence-driven CQC. If I can just start by reminding people that we've seen the strategic framework for knowledge and information back in April, and there's been a great deal of engagement within the organisation, to some extent outside the organisation, and including with a number of non-executive colleagues in getting to the paper that you've got today and the strategy that lies behind it. If I start by what we're not asking for, just to be really clear, we're not asking for endorsement of any resource bids at all, and that's true as well in the public engagement strategy that you're going to see. For completeness, we have included the expected capital programme, some of which is already committed from 14-15 and where appropriate has already been through the board. Some is what we will expect to spend in 15-16 and beyond. But the key point is that we will go through the investment committee and ET in the standard way for any bids, and for where things cross a threshold, we'll obviously bring those individually to the board. It's also, I think, an example of where we're trying to do 2 things at once. We're trying to plan for the future, so we've got a decent basis on which to make decisions on capital and decisions on staffing and resourcing. But what we haven't been doing is is a lack of operational activity and intelligence while we get our plans right. So as David mentioned, the GP intelligent monitoring, for example, came out on Monday. On Thursday, tomorrow, we'll be doing the mental health intelligent monitoring. So we're balancing those two things, but fundamentally we know as we discuss the capital programme, we need to have good plans in place so that we've got a solid basis for investment. The work is thoroughly led by Emma. And I think she's done a fantastic job on it. So some of the questions I will shamelessly pass over to Emma, I suspect. But just to sort of closing one or 2 points, although there's quite a lot of detail in the document across the 5 work streams that are set out in the strategy, we've also tried to pull out the big 10 items on page 10, coincidentally, because we wanted to give a sense of what the things are which might cut across those work streams. And there are some quite big deals we've talked about in this board and previous boards. For example, having a comprehensive view of surveillance that brings together whistleblowing, safeguarding concerns, complaints, as well as all our quantitative data. We want to get to a position in many sectors as possible where the data is able to inform as effectively as possible the inspections, and a place where our reasonable position is that there is equal emphasis placed on what the data is telling us as there is anything we might see with our eyes and ears. It's not a question of data being subservient to a site visit or the other way around. We want to place and make a reality of that nature being intelligence driven. And the last thing I want to point, even though we've got a coffee break in between, there's a strong link between this piece of work and the public engagement strategy, not least around how we use the data that members of the public give us in our qualitative information. So I'll pause there, and Emma, do you think I should add anything to that, or should we go straight for questions?
Thanks very much, Paul. Emma, did you want to add anything to Paul, or just...
No, thank you.
No, okay. Any questions for Paul and Emma on this paper?
I think I might have asked you this before, so you won't. I mean, obviously, I'm particularly interested in how views and experiences influence our inspections and assessments. So, can you assure me or reassure me that will be done in a sort of systematic way that make sure that we do get an accurate view of the service that people are receiving? So it is largely the qualitative angle, but it's to make sure that we don't get too good a view or too bad a view, but we actually get a kind of high quality that actually represents what the quality of the service. Yeah.
So yes, that's a really key objective of this strategy, and I think is a theme that crosses over, as Paul said, between this document and the public engagement strategy. So we want to hear more from people who use services. We will want to do that in a methodical and sensible way. So we want to understand which sources give us the best intelligence. So we have a number of different media that we can exploit to get more information. Part of that is sort of national mechanisms via websites, people contacting us directly. Some of that is our local relationships on the ground and how we capture relationships of small community groups, for example. What the commissioner feels would be another example. And what they're gathering directly from people who use services, so secondary sources. Through the work of the strategy, we will be looking at all of those different media, all of those different streams, and assessing the difference between them, not just in terms of value from an intelligence and an analytical perspective, but also looking more broadly across, are we representing the various segments of the public? So we have agreed a framework for segmenting the public, and we will look to get coverage across all of those segments. Now, some of those will come naturally through digital media. We know certain types of people are more likely to give feedback via those routes.
there are other groups of individuals that we will need to be much more focused on, much more proactive in going out and talking to them. And that's where I think the qualitative work is going to be challenged, because we will generate large quantities of qualitative data that we will need to manage and turn into something that gives us insight into the quality of care. So the process we're going through is to increase the volume, understand what that tells us, and develop a sustainable methodology to be able to feed that into a comprehensive surveillance methodology and something that informs our lines of inquiry during inspection.
Well, first of all, I thought this was a really good paper and is very much in the direction that we should be going, so that was very good. And one of the reasons I thought it was, I liked it, is that I think, you heard me say at a previous meeting, I think it is unsustainable that we have a model. It's a necessary step, but it's an unsustainable long-term model that we see inspection as trumping all our other methods of intelligence gathering. And this seems to me to be taking us towards something much more comprehensive and sort of composite. You could equally argue that the qualitative data, the complaints, but its feedback in a more general sense, its reports about acute incidents. There are other areas of information that need to be brought up to a certain level to allow us to be less dependent on inspection. And I don't want this to be seen as a criticism of inspection, because I'm a very strong supporter of inspection. There are some things that only inspection can do. But at the moment, we are slightly over-reliant on inspection as the method that everything else feeds into. And in the end, well, you have all the data, but actually inspection gives you the answer. And I don't think that's where we can expect to stay. Having said that, there's just a couple of things. One is the refinement of the data items. We had an interesting session yesterday, Jennifer and I went to about it, which was very helpful, actually, about a more detailed discussion about some of the data items. But one issue, I think, is it 160 acute items? I suppose you could argue that if they were the right 160, right item, you wouldn't need 160. You would need 16 or something. So there's a task here in refining the real, the most telling items of information. And it may be also that there are some gaps as well. I don't know absolutely what they are, but I think in some of the other areas, particularly social care, primary care, mental health, there are some gaps in what we know, what we have data items on, and we might have to have the courage to say to NHS England, to the Department of Health, there are some, we have to be collecting information that we don't at the moment collect, and there is an assumption against that at the moment. Because it's a burden on the system and all of that, but in fact we may have to say that there are some gaps in what we collect, and we need a new set of items to be added to the data set that trusts routinely put together. But with that refinement and that identification of gaps, I think this is definitely the right way forward.
Yeah, I think it's a very good paper. Thanks very much to all concerned. Also, it is aimed, as you say, to information specialists, so it's obviously very technical. But as we were discussing yesterday, and speaking from previous experience with the Healthcare Commission, the amount of knowledge about this area among system leaders and amongst leaders in the system within the NHS is fairly limited. And I think there's a scope for us to, we were saying yesterday, to maybe write an essay of some sort and put information out on what we think the promise of this approach is over time, and where we think what it can and what it can't do and where it's going for wider digestion. Because before conclusions are jumped to, before we're ready to say that this system is better than it is. So I think that would be very useful at the moment, and that leads into where we're going with our general approach to regulation. And also, it's groundbreaking internationally. That's the other thing to say, which is a hook to hang it on, and that it may be politic to do this sooner rather than later.
Emma, on that point, when we met yesterday, you said you would out of writing a research paper or an essay on this is something you're going to follow up.
Yes,
yeah.
Absolutely, yes. And we hope to be able to deliver that early next year.
Yeah. Paul?
I think, firstly, very helpful to have the positive feedback as well. Thank you. And it has been something that the team has done despite being down on where they wanted to be on resources. In some areas, we're down 50% on analysts. So to give a sense of what people are doing despite the challenges. There's, as well as our own work, I think both the questions, it touches on what the overall the system needs to do, because there's no point in us collecting data, for example, that somebody else is, or somebody says we should be doing one thing and we're saying another. So we're working quite closely, particularly with NHS England and Tim Kelsey within that, and Andy Williams within the Health and Social Care Information Centre. There's a publication which I'm pretty sure is today, which is the 2020 view, the framework for action for the use of information right across health and adult social care. And it comes on the heels of the 5-year forward view. It was similarly done by the group of arm's length bodies. Emma and I had pretty strong input into that. David sits on the National Information Board. And one of the things that commits to, and we have signed off from government on, because we managed to get it to be a cross-government document, so signed off as policy by government, is to an annual statement to the Secretary of State saying these are the data gaps. This is where we need to fill it most quickly. Mental health would be a great example. Adult social care is a huge example. And being able to come together as a system and say this is where we're missing things just seems to be a very important new step.
Paul, one of the interesting facts that came out of the meeting that we had yesterday was that the information where there's the strongest correlation between the hard information and the results of the inspections, or whether one determines the other, was actually the staff friends and families test, and the staff question, would you recommend this as a place to work, and the patient surveys. I mean, those are both areas that people would have put in the soft category, but actually they're clearly hard bits of information. And actually, if we had that information across adult social care and primary care, which are two big gaps, if you like, that way you were describing, that would be hugely important to us. And actually the fact that it was the staff survey information was much more correlative to the results than, for example, mortality information is, I thought, was really powerful. Anyway, I think it's Robert. Yeah.
Question. One thing to produce information, data sets, and so on and so forth, and to develop all that, which is, I understand and applaud this strategy. But could I just ask a question as to whether something is included in it, and it may be, which is that is the influence the collecting of data set information has? In other words, first, there can be unintended consequences when it is known that you are collecting information, it's known you're going to publish it, and what that behaviour is may change according to what it is you publish. And I would hope that part of our strategy is to ensure that we look at the unintended consequences and we actually analyse what consequences we might intend to come out of that.
It's absolutely right. It's one of the reasons we have this conundrum about how many pieces of data to publish as well as to collect. On the one hand, we know there are particular bits of information that probably are most valuable. Also, we know there's an important research literature that the things that you measure have unintended consequences, and people will game the system. So there is a value in having a wide range of performance measures. So we are trying to think through that one.
Just a couple of points. I thought this was very good. I've said that to Emma. I think the ambition is very impressive. Just a couple of points. I think it would be really helpful for our credibility if we could show that we have learnt from other countries and what we're doing. And, Jennifer's saying we'll set an international standard, but obviously there are other people doing some things, and I think that would be that would kind of sort of slightly broaden it out. If we're going to publish this, I think that would be really helpful. In terms of publication, the only thing that struck me was there are several references here to staff capacity and the need to build staff capacity. And looking at this in slightly cynical mode, I thought, well, that sounds as if we're a bit weak on that at the moment. And I just wonder whether that's what we want to be saying to the world, or if there's a slightly different way of saying that, because it left unclear what we think our own problems are at the moment. You know what I mean? It's sort of setting a great ambition and trying to encourage people to think of us as a place for really excellent analysis, but it's also suggesting that we might not have very good people. So just a sort of thought about that. And then the other point was just on the last part of it, the making an impact part, which I almost thought is almost a separate paper in a way. And I don't know if you really want to wind it up with all this, but this was the only part where I became slightly less convinced because it seemed a little bit passive. There was an awful lot about asking stakeholders what would be useful to them. And I actually think, you know, if we're developing a new model, we need to be more confident in ourselves of what we're going to publish and not spend an enormous amount of time going around asking other people what they want, because they don't know what they want until they see it. And I think we need to be very, very clear in this section that our aim is always to improve the quality of care. You know, our aim is not to help X think tank do a paper on. Do you know what I mean? I just worried that we were slightly losing sight. It's the only place I had a worry in this paper. Our aim is to improve the quality of care. You know, there's no point publishing stuff or writing endless papers unless that is the eventual effect. That's all I thought.
Well, I think we'll just make those changes. That's really helpful. We can be confident. I think what we're hearing is that you think it's a good strategy. We should be clear about the impact we're going to have and be proactive. We'll make sure it's balanced with continuing to listen and hear from people. And on the capacity point, let's look at our language. Our capacity, when we're saying that, we mean numbers of people, not the quality of the individuals currently here.
That's not skills.
So we just need to be clear. So there are places where we do need to build our skills, but our concern absolutely isn't with the people that we currently have. As part of our business plan for this year as well as for next year, we've been planning to increase the size of the Intelligence Directorate as well as where we need to the skills.
Yes, just one point. There was some email traffic about this yesterday. It would be very interesting for the CQC to say, right at the beginning, Paul mentioned that the intention is not to have data at the expense of inspections, that they are complementary or reinforcing. But to take Lewis's point, to actually be able to articulate what inspection adds over and above the analysis of data, especially, and this is what touched off the emails yesterday, there are increasing amounts of data. I mean, for example, the fact that it was announced this week that survival rates for various types of cancer are now going to be published. Every surgeon will either be forced or through peer pressure declare their mortality rates. I think it is important, given our model, to be able to say, this is why we do inspections. And I think the next time, maybe that's something for the, it's sort of, maybe it's related to some of the issues we were discussing earlier about different models of healthcare and what our role is going to be. Perhaps we could, as part of that, touch on this issue, or at least, be able to have an opinion on what inspections add. I wasn't trying to say yesterday that I didn't believe that I didn't believe in inspections, but being able to articulate it clearly, I think, is very important for the CQC. And so I think it goes hand in hand with this excellent work on intelligent monitoring.
Can I try and address this? Because actually I have developed some slides that I'm happy to share with you, Michael, under each of our 5 domains: safe, effective, caring, responsive, well-led, what things we really look primarily to the data sets for, and the things that we can't get from a data set. So under safety, for example, we haven't yet got a data set that tells us whether equipment is being checked. We have to go and look at the environment to see if it's a safe environment. Medicines management, we rely on looking at, when we're there, records and how records are managed. All of those things, there aren't any data sets, even in the acute sector, where we have more data than anywhere else. Whereas if you look at the effectiveness domain, we're almost entirely dependent on data. I can't go into a hospital and say what are the know whether that hip replacement has been done better than anything else unless they can show me the data from the last 100 or 1,000 hip replacements. So that domain is very data driven. Caring, I would say, is about half and half. It is a combination of what we learn from our own inpatient survey and the other surveys like the maternity survey, but it's also what we observe, and we do try very hard to see what the balance is between those two. Again, responsiveness, it's partly data-driven like the waiting times, but it's also really going and asking how are patients with learning disabilities being managed in this trust, for example. And the well-led domain, again, it's half and half. The staff survey, which I go on about a lot because I do find it very useful. But again, it's about talking to the staff on the ground and getting the corroboration from staff on the ground so that we can understand what the staff survey means, for example, as well as talking to the managers. So there's a balance, and it's different within the different domains.
I think it would be helpful. It would be good to articulate what you've just said in sort of shorthand, and I think it would be really helpful to do that. It would also identify, maybe, Paul, some of the gaps that Lewis was alluding to earlier on. Good. Thanks very much. I think we can break for coffee now, but can we make it a 10-minute break, if that's all right? Thank you. Right, can we carry on? Paul, you're taking the next paper, Public Engagement Strategy, and we've got Chris. Chris is here to answer questions as well.
Thanks, yes. Chris is our engagement director. So as with the previous strategy, just to be clear that, again, we're not asking for resources or final confirmation or any of that, but we have included numbers in the paper, similarly as with the knowledge and information strategy. We've had a lot of input also on this paper from non-executive colleagues, including Kay and Anna and a number of other people as well. And in many ways, there is a similarity to the knowledge and information strategy in that what we're trying to do is have a clear plan and base that plan on the research that we've conducted, which Chris will speak a bit more about. Similarly, again, we've tried to pull out in the covering paper, pages 2 and 3, the big items that we want to focus on as a result of this strategy. And we've also, because in some way public engagement can be mistaken for being fluffy or nebulous in its outcomes, we want to be very clear on what the success measures are. So you'll also see those in the covering paper as well as in the main strategy. Healthwatch are an important part of both supporting our development of this strategy, but also in the rollout of it. And as I'll finish with in the same way that I said on the knowledge and information, there is a strong link between these papers, just not in the way they're presented, but surveillance requires good knowledge of information from the public. So we're working pretty much hand in glove on those two things. Chris?
Thanks, Paul. I think just to add to that, there's a lot of work that's gone in the background to make sure that the things that we offer as part of the public engagement strategy are deliverable through the work we'll do in knowledge and information. And just really to say that this strategy builds on the engagement we've had with the public since the launch of the CQC strategy 18 months ago. And the 4 key areas really resonate with what the public, people who use services, have told us they think our focus should be. So raising awareness, listening and acting on people's views, working with them to develop how we do our job, and providing high quality information.
Thank you, Chris. Questions? Kay and Anna? Take a mouthful, Kay. Take your time.
No, all right. Okay. Yeah, obviously I've had quite a lot of input into it, so I think it's good. And what I would find helpful is if, say for example, we're about to do an inspection of a mental health trust. So can you describe to us what the engagement around that might be, in theory, in practice? What, from the sort of very beginning when we decide we're going to do an inspection to the end when we publish the report or even follow up. Yeah.
Thank you. So I think one of the things that this tries to do is to have a more continuous view of how people are viewing services in our local area. So we would have and want to maintain and build ongoing relationships with Healthwatch, obviously, but also with the other stakeholders locally, so that we can access opinion on services from a variety of sources. So our aim would be to have regular ongoing engagement in every geography that would in part build into what would go into intelligent monitoring. And then we can use that at a period before an inspection to help build a picture of what we think, what the issues are. And what we'd want to do is always to test that with the public prior to an inspection. Obviously, we'd have, on that inspection, we would have people who use services as a key component of that inspection team. So their voice and their information and their insight would be a valuable part of the inspection moving forward. And at the end of that process, when the information that we publish to the public, we'd want to make sure two things. One, that the information resonated with the public, i.e. it spoke to them about their services. And we'd want to make sure that therefore they were involved in the sort of how that's built, and how we then share that back with the community. So there's a sense that it isn't just a thing that happens and then there's no feedback on how that service works. So we want to make sure that the channels aren't there just to pull information from individuals and groups, but also to present a picture of what we found and what we see. We see, even going back to the work yesterday, that when we publish information about what we think, that's the beginning of a conversation with people to tell us about what they think. So we want to make sure that develops and becomes an ongoing conversation.
Actually doing the inspection, talking to people who use services is presumably going to be quite an important part of that. Is that right? And so how do you envisage that's done? Because you're thinking of people with, say, a learning disability or people with dementia, maybe people who don't speak English. Are we giving thought to how we're going to access their kind of experience and views of the services that we're inspecting?
I think that's why the local partnerships in particular groups are really, really important. We've already developed, I think, through the work we've done on Experts by Experience, good links with particular groups, and I think we need to exploit those more and perhaps develop further. There are some parts of the country where we have our links aren't as strong as they could be, but absolutely through the inspection teams, having people who've got access, who've got current access to local groups and current experience of using services is vital, because they can offer a real insight that you can't get from just from the inspection teams or just from the general engagement work that we do. So we think those are very important in providing a real sort of dynamism to the information that we present, and also that to make sure when we go into a service, we're able to talk to people who use services in a way that's meaningful to them and represent their views more effectively.
Just to add to that, I mean, I think the example of Mental Health Trust is a very good one to take, because I think it's actually a very complex one, and it's complex partly because of the huge geographical area that the services cover, and by the fact that obviously a lot of the care is being delivered in community settings. So I think it's a combination of different approaches. It's trying to pool all the qualitative data that we have from share your experience, patient opinion, whatever it may be. It is adding to that whatever we can find out from complaints, which I think will also be particularly valuable in the future, and we're coming back to later on. There may also be whistleblowing concerns that can help. In the community setting, we do have the Community Mental Health Survey, which is valuable of giving us if you like, a more robust view of the in terms of making comparisons between mental health trusts. Then clearly, at the time of the inspection, a lot of this is a question of the observation during the inspection. And that's where I think the experts by experience come into their own. And they will be spending a lot of their time talking to different service users in different settings and observing. The area that is perhaps a bit different from the acute is in the patient and public listening event, which we may have to try and do in multiple different areas just because of the geography, whereas with an acute trust we can usually say, let's find a hotel quite close to the acute trust, and that will serve all. So I think it's how we bring all that together, and the idea is that as much of that is done before we go on site, and will then feature in the data pack, but then we add to that by what we hear during the inspection.
Thanks very much. So I just wanted to say a couple of things, really. I mean, the first is that I've really appreciated the fact that we've been able to have conversations about this over the last period, and that we've kind of held it back until we were all feeling more comfortable. Seems right and proper. So thank you for that. And I do feel in terms of the kind of overall structure of this now, the kind of strategic approach, that it feels right and it feels good, covers the right bases. And as colleagues who were working on this know, I was concerned that we were being very ambitious and not being honest about the practical reality of what we could deliver in the first instance. And I want us to be ambitious, but I want us to be honest about what we can deliver in the next period. And I think this now does that. So I'm pleased to see that. I think Kay's asking questions about the kind of practical application and kind of detail of this, and I think that's absolutely right. And I suppose what I would like to say, rather than sort of follow up on some of those specifics, is that I would really appreciate that ongoing conversation. So in the implementation of this, you talk about intra-organisational working groups to deliver, but actually I think it would be a really good thing to have some working with other bodies outside, and I say that not just with a Healthwatch hat on, but also with the clear sense that this is actually now a very crowded but slightly chaotic space. So everyone is, all the system players are under a duty to engage and involve the public, and everyone is finding their feet and doing it in different ways. And actually, what I hear from local Healthwatch is that they're all falling over each other at the local level, where there's a kind of great inclarity for local Healthwatch about how all the bits join up and add up to more than the sum of the parts. So it's really important that those conversations with everyone carry on, so that because there's some quite big things in here, contracts with local regional bodies to deliver public voice, and potentially big expansion of experts by experience. This is all potentially very big spend, and it might be the right thing to do, but actually if other people's plans develop in other ways, it won't be the right thing to do, because it won't join up and it will be inefficient and potentially ineffective. So I just would counsel continuing to have those conversations on the detail, and obviously I'd especially like that with Healthwatch, but I would like it with other organisations as well, and especially some of the other system players.
So we'll absolutely do that. That's categorical that we'll continue to engage both within our organisation and more broadly. But I think the point you pick up about the regional partnerships is really important, because it just differentiates a little bit between the all the work that we will do pre, during and post inspection, but that is nonetheless a moment, or it's a block of time, and it's really helpful to have that because it focuses everybody's attention on the issue. But it's just as important that we understand on an ongoing basis, and that's one of the reasons why we want to invest in these regional partnerships, so we don't expect the set of voluntary bodies, statutory bodies, to be working the same way in different areas of the country, but we need to know consistently what's happening in the different health and social care providers there. So we really want to have that access to an ongoing flow of information, but clearly we want to do that in collaboration with other people, so we're not duplicating.
And I suppose I I can only speak for Healthwatch and local Healthwatch, but I know that some local Healthwatch, on seeing something like that, would immediately say, well, actually that's something we'd love to do at a regional level, is pool our resources and kind of deliver something more like that, rather than have something else potentially competitive created to do it. Now, that's a conversation, but I think it's really important that we have those discussions before we run off down any particular path.
Well, in the light of what Anna's just said, can I just check, are you saying we shouldn't approve this programme because we don't know enough yet to know? Wasn't what I was going to say, but now that you've said that, I just wonder.
No, I'm not saying we shouldn't approve the programme, but I think we should encourage the executive to deliver it in a way which makes sure that if other people are able to deliver some of this for us, that we work with them to do that rather than creating something new. And that should be the presumption. So the ambition that that CQC has access to regional ongoing voice at a regional level, I think that's absolutely right and proper. The mechanism for delivering it, I think, still bears a little bit of exploration, and that means talking with other partners about what they're already doing or what they could do, and how we could do something which suits several people's purpose.
Yeah, because the £9 million, which appears in one line in paragraph 6, is a lot of money. And I know you said, Paul, that we weren't here to discuss investment, but I mean, that is a lot of money. So I think, I'm never quite clear. If we're approving this programme, what point does someone come back and say, gosh, and actually it's £9 million? And then the really important question, I suppose, is how much of that is about technology? Because quite a lot of this paper is about, web technology, and how much is actually, salaries and things, and how much is web? Because obviously the danger of web is you can get into big contracts that are quite expensive if you're not careful.
Well, Chris can probably do some of these details. We wanted to put the numbers in to give an indication. It's not a question of we're not spending any of this money at the moment,
right,
and it'll suddenly be £9 million. So for as it says after the 9 million, 8 million is non-pay, including the Experts by Experience programme.
Yeah.
That's a multi-million pound existing programme. What we're trying to say is within the envelope that we already have on engagement, this is how we want to deploy the resources most effectively. For example, on Experts by Experience, where we said we'll bring a report back to you, we will be recontracting, that's clear. It will absolutely go over the £1 million mark, and it will therefore mean there'll be a discussion at the board about that particular procurement. And simply anything else that goes over £1 million would similarly do so. Otherwise, it goes to investment committee or executive team.
Okay.
Just to try and bring both points together, I think that the strategy is absolutely in the space of saying who are the best partners to help us to deliver this, rather than trying to create anything that we would create ourselves. There is absolutely no point in trying to recreate something that is better done elsewhere. And to Camilla's point, the vast majority of this expenditure as it currently sits is around how we work with organisations to get people who have experience of care into our inspection programme. The vast majority of that work is the vast majority of our non-pay expenditure is in that area and will remain so. There isn't a massive IT contract that we're looking to let. This is really about really practical local relationships to pull together many strands of people's experience of care into our inspection programme that is absolutely vital. So it's absolutely in that space, and this will be lots of people on the ground to deliver our inspection programme.
David, can I make one last point, which is a bit different? Because on our number two, which is obviously very important, listening to and acting on the public's views and experiences of care. And actually, it's also number one. People understand what CQ's role is. I mean, we have a major issue at the moment in that we don't investigate individual complaints, and we've talked about this before. People find that very difficult, and actually there's a paper later on which I think might help, in the way we describe that to people. But that is obviously, we've talked about it before, that is a big issue for people. The other issue that is coming across my desk all the time is that people who, not the people we're about to try and contact, but people who have already experienced poor care are coming to us and telling us about it, and we are not acting on it. So I just feel, and sometimes we don't act on it because the inspection has just happened. I mean, there's one that you helpfully sent me something on last night, Chris, where, the person actually was told by the CQC inspector, well, I'm really sorry, we've just inspected that place. And the CQC inspector apparently also said, well, we'll only hold your information for 3 months, which I thought, I'm sure we don't do that, because this person then thought, but there are a lot of people in the system, and I mean, I've talked about one or two of them here before, and everybody's aware of, or everybody has their own individual context. There are a lot of people around who, they only want to make the system better. They're not asking for compensation, they're not complaining on their own account. The person I dealt with last night almost died. If he hadn't been a doctor himself and basically ordered people to do certain things, he would have died. Nothing has been done just nothing has been done. Now, that's not just our fault. It's about the gap we've identified in the system before, about the fact that there is nowhere that really investigates individual complaints. But it still worries me that in terms of what you're trying to do here, which is building up the public confidence that we are on their side, we still don't quite have traction on this issue of what do you do when you have a really significant complaint to make about an institution which has recently been inspected by CQC. We're not going to go back in, and we sort of say we're doing ongoing monitoring. I'm just raising it because I just think that's the bit that's missing from this, and we can do lots of wonderful public engagement, but unless we crack that other piece, it's not going to work completely.
There is a strong link between this and our approach to intelligent monitoring. So the work that Emma's team and my team have done, I think there's a bit about how we've been, I think the organisation has in the past been very good at the way it uses data to understand risk and go and inspect. And I think it's there's a journey it's going on about how we use people's voice and other experience to do the same thing. I think we've begun that journey with how we use intelligent monitoring, and for as probably Emma described in the earlier strategy, developing the right channels and being confident about the information that we receive, and then making sure that forms an intrinsic part of what we choose to prioritise in terms of inspections is really important. So that handshake of when you tell me something about the care, when I tell you something about the care I've received, I get an obvious sense of what you're going to do with that is a really, really important point. And I think there's a big play between raising awareness and listening, and why those two things are 1 and 2 is for exactly that reason.
But it's also the point you have into it's acting.
Yes.
This paper is great on listening. What we are not so great on is acting. And that is where I think we still have it, and we're getting better.
Yes.
We've got a deficit in the public confidence. That's all.
So we can look back for what we can do more in this paper, but we do need to settle what we do and don't do with individual concerns raised. So last week I was out on inspection at Domiciliary Care Agency. One of the reasons we were inspecting or re-inspecting was because of a particular piece of information that had been given to us by a member of the public about the lack of care provided to their mother. The inspector and I then spoke to that individual and their mother. We were then confronted the provider with that information, what they were doing about it. What we were absolutely not doing was settling that concern or complaint for the purpose of recourse. We absolutely were investigating, to use that phrase generally, so that we can make a judgment about care, and it was about an individual case. And the way we're trying to systematise that into the conversation we've just done on the enforcement policy, which just tries to be very clear that the criteria for enforcement that we're consulting on are how serious, persistent, or multiple the incident is. If it is serious enough, if an individual incident crosses the seriousness threshold, then we need to act. And I think part of our explanation of why we are engaging with the public in the way we are in the strategy is because we do want to use the information, but I totally take the point that is not well understood, and that difficult distinction between recourse and what we can and should do with the information isn't clear to people.
Final point. I mean, it's not just it's not clear. It's that we're also not always acting on information which has wider relevance than just the person who's made the complaint. And I really do. I mean, Anyway.
It is variation. And I think some of the changes we've made, Camilla, along this, I sign, I don't know, probably 40 or 50 letters a week that go out either to MPs or to people that have raised concerns. And I think now probably 80% of those letters have, and if you're still unhappy, here's a number and here's the email address of the inspector or the inspector manager, and they'll speak with you directly. So your point about...
That's not the point, David, though,
okay.
Is it?
All right.
Sorry.
Well, what I was trying to say, it probably isn't.
I mean, it's good. It's really good, but...
What I was trying to say is the criticism of us is we don't listen and we don't act. And I think what we've been trying to do is say, we will act, and if you want to pursue this further and you're still not happy within the terms that Paul has set out that we're not here to resolve, then please speak to this person and we'll bring it in. The accidents of somebody raises something the week that an inspection's taken place, and we're not going back for another 12 months. So what can we say? And what we're trying to say is we will speak to you about this information. So it's not an anonymous hit this helpline or write to enquiries at cqc.org.uk, but have a personal conversation with an inspector or an inspection manager about what your concerns are and what we can do about it. So I would come back and say it isn't that we're just not doing anything. I think the fact is that we all, and probably you as non-executives more than people like me, act as conduits for people that are not happy with what we've done. And that's absolutely right and proper. And it's absolutely right and proper it's raised with us. But I think what we have been trying to do to respond to exactly those is say, and if you're still not happy, speak to this person. And I would like, it may be you still don't think that's adequate, but I'd like to present that to you as an example of how we are trying to do more differently to give some personal feedback to people and close that loop.
The examples I'm seeing are where inspectors are doing that, and they're probably spending a lot of time and putting a lot of effort into having those conversations. But that does not, and it's not the inspector's fault, it's really about our role. That does not always translate into taking it any step further. That's the gap. I think we're getting much better at listening and having the conversations, but people are going in and having these meetings, and then they're thinking, well, what's going to stop the next person dying in the operating theatre? That's the problem. That's all. That's the gap.
Can I sort of because I think that there's a real. I mean, although the public engagement strategy comes out of kind of Paul and Chris's stable, it affects all of us in the way that we interact with people, and there's clearly an incredibly important role for our inspectors across each of the three directorates in interacting with people. I do think that we've got a really big issue about the expectations that in a variety of different ways get set for people in terms of them coming and talking to us, because we cannot, we don't have the powers. It's not that, that kind of we don't think it's important that people get individual redress when that's necessary. We don't have the powers, and we're not resourced to do it, because if we were resourced to do it, we'll have an awful lot more people than we have at the moment. So I think that we all have to be very clear about what it is that we can do and what it is that we need to do, either when people come into us at NCSE or when they're contacting me via social media or writing to you, Camilla. I mean, we all need to be very clear about what is the boundary that we've got. The second thing that we've got to do is that we then need to take the regulatory, to have the appropriate regulatory response, and that that sometimes will not satisfy people, because the appropriate regulatory response is not hanging people out of the window by their toenails, which sometimes is what people want to have happen. But we do have to make sure that we're kind of taking an appropriate assessment of that, and that we get inspectors with their inspection managers talking this through in terms of making sure that that appropriate regulatory response is in place. It does sometimes happen. You'll get the ones where it hasn't done for whatever reason, but there are a number of other circumstances where actually appropriate action is taken. The third thing that I think that we still do fall down on, and Kay and I had this just only recently with somebody, where people have raised concerns with us. Actually, we have gone back and talked to them, but then we've not fed back what we've done with it. And sometimes we have done something with it, we've just not fed it back. And sometimes, that's difficult because people have shared that information with us anonymously, and so that's tough. But sometimes it's because we've had a breakdown in our system internally. So I think the work that is coming from Caroline Fawcett in Eileen's team links very much with what we're doing on the public engagement strategy, which is how do we respond to the concerns and issues that people are raising with us, and what do we put in place to make sure that we close off the loop. So I think there's various bits along the way that we've got to get better at, and is kind of part of this, but it absolutely is the responsibility of me, Steve and Mike to make sure that that's embedded within our teams as well, and we're not kind of depending on Chris's public engagement team to do it for us.
Well, Andrew's almost said what I was going to say, but if I can just put it very briefly in my own way, we've got to be very careful with our language, because when we say we don't look at complaints, people's complaints, of course we do. What we don't provide is a remedy for the individual, and sometimes we will actually investigate what people have been saying to find out whether it was true or not in the best way we can, because that's relevant to our systemic investigation. And what we need to do is be really clear with people when they come to us what it is we're going to do with what they've told us, where else they need to go to get the rest of what we're not going to provide them with, and then we need to give the evidence the value that we've got from their information by going back to them individually and telling them what we've done with that information. And if we just stop at saying we don't deal with your complaint, you're bound to get a much greater level of dissatisfaction than if we do what I've just suggested. And that, I would respectfully suggest, is as much part of the public engagement strategy as it is in relation to the operational work of an inspector.
Thanks. I mean, in some ways, my point is more of the same, in the sense that it isn't just what we do; it is also what we achieve as a result of what we do. And I think the bit that, although I think it's quite a good paper, I think the bit that is missing for me is the explaining to the public, it's about public awareness in a slightly abstract sense, when in fact the thing that will make the public aware of what we do is when we tell them what changed about their local service as a result. So it's not even the fact that we processed the concern, it's the fact that as a result that service did the following, and then it was better, and then we went back and the inspection was a positive one. So that sense of what we achieve, and also how quickly that was done, because that's the other thing. So what we were talking about earlier, when we were talking about the actions that we take and the time that the protracted period that can go on for some organisations, I think that's the bit we have to get into the public engagement. The public will be engaged once they realise that it makes a difference when we get involved. And at the moment, I don't think we've got. We can raise awareness of our role. All right, that's sort of useful. We can say what we do if you contact us. That's helpful. But what will really matter is if we can spell out what the impact was. And one of the reasons why we're not very good at doing that is I'm not sure we know ourselves what the impact is yet of what we do, because we're in we're in that period where we're re-inspecting and that sort of thing. But that I think is the key to our public engagement. I've mentioned this before, but when we have these private emails, summaries that come around every week from David about what has been done about services, and they are usually in social care, and they are usually cases where there has been a story of abuse, and then some action has been taken, and that the care home has had to change, or it's been shut down, or the people have been arrested, and I look at that every week and think that is what people need to know happens as a result of what goes on here. And I understand there may be legal reasons why we don't make that public, but could we not make some of that public? Because if we told the public that that's what happens when things go wrong and we're involved, things get shut down, abusers are prosecuted, then I think they'd understand our role, and then we wouldn't be talking about engaging them, because they would be engaged by the fact that it's obvious and because that engagement is not just about what happens to their own particular concern, it's their understanding of the broader benefit in other parts of the country to what we do. So I think this sense of what is achieved is vital, and at the moment I don't get that. I suppose I have in mind a very clear sort of explicit flow of information to us and the impact that has on the system. How many trusts were required to change? How many care homes were closed, or or for that matter improved, took a few months, but then were better. That's the information, and then I think public engagement will just follow as a result.
Well, I think it has to be both and. I don't think... it would be brilliant if we could just do our job and then everyone would be engaged. I think we have to have a set of systems and a plan that's building the confidence at the same time and encouraging people to tell us about their concerns. As Andrew was pointing out to me, we have a lot of people coming to us mainly through NCSC. So as a measure of engagement, there is clearly engagement going on. But I think what you're really highlighting, the end result is at the overall level being able to show the numbers of things that have improved or shut down, and also for the individual what has happened at their care home, practice, hospital, whatever it might be. And I think we just take that away and work it into this piece of work, how we can close a loop, I think is the language that Chris uses, so we're always clear what the impact of our actions has been. That's something that I know Paul's raised a number of times as well.
Just to follow that up, we often talk about our website here, but I think the first thing you should see on our website when you go onto is what we've achieved. How many trusts are better? How many trusts have got a better inspection following the first one where we told them what was wrong, and so on. And it would include care homes that are either better, or if they didn't improve, decisive action was taken to protect the people who are there. I mean, a lot of this, the care home part of this is really important, because probably outweighs the importance elsewhere, because that's the area where what we achieve and what people want from us is complicated by the fact they're often acting on behalf of somebody else, and getting that up front, the kind of information on our website and our documents is key.
I mean, just one of the other things to say is that we do that through the engagement process from a kind of media point of view as well. So whenever we have serious action that we've taken with a care home, we do share that information through local press releases. And I mean, if you look at the information that we get on a regular basis about what gets reported, there's an awful lot of that does get reported at a local level, and I've agreed with Chris's team kind of what we will do when services that are inadequate are rated in adult social care, and how we'll share that information. Equally, what we'll do when we've identified outstanding services, because it's not all bad in adult social care. There are some areas where we've actually got to take some pretty drastic action to protect people, but we also need to say you don't have to be scared about it, because there are some good places too.
Two more very quick points. We ought to move on, but Jennifer and Robert, you had Okay, Jennifer.
Thanks. I thought it was good, ambitious. Two issues. One is I have no idea what the right level of spend is in this area. So I guess an assessment at some point as to how much is enough, given what we know about how impactful it is. That's number one. And number two, on the regional contracts with organisations who provide CQC with regular reports on views and experiences of care, in a sense, the primary people who should understand the patient experience are the providers, isn't it? And I don't know to what extent we could somehow, through this work, stimulate providers to be collecting the right kind of information that we ourselves can then rely on, so we don't have to let regional contracts. And I don't know whether we've done or had thought about a thematic review in this area, because there are some trusts who regularly, for every single patient, collect information that we could. So if some are doing that where we don't actually have to spend money on doing it in a third-party way, is there some way we could stimulate that activity so that we can spend less?
Yeah, I think Chris wanted to come in on this, but where we have confidence in the individual providers, we should absolutely be doing what you're saying. It won't always be that way. We'll want to, particularly if we've identified a problem in the way they do, look at and assess concerns. But also the great value of the regionals is it's not provider specific. It's a really good opportunity for us to pick up a whole series of questions about care, concerns about care and good care across different providers and between the cracks in providers.
just to say, we will use provider information, and there are some really good examples of it. But as Paul said, what we're trying to do with the local engagement is to look cross systems, so not just in individual experiences, but across the areas. And just going back to the point that Lewis made earlier, about 1,000 releases a month go out to local media, and they stimulate information back to the website. So we do report both good and bad care. Things like the 1 year on report, which looked at the organisations that have been through special measures and what happened to them since. I think they're really powerful, and they're absolutely what the public want. And what we've got to do is to make sure we can capture the information to make a meaningful report to the public. But we're absolutely on that, and that's very much part of what 4 is about, which is high quality information. High quality isn't just about the statistical reliability of it; it's about making it sure that it's right for the people who use it and it's meaningful to them.
Just a few points. I'm just very wary of this figure that 75% of people who use our website find it easy to get information. Now, maybe I'm hopeless, but I think it is actually very difficult. And just to give a simple example, there's been a report on Chelsea and Westminster Hospital, which happens to be my local hospital. You can track down the summary relatively easily, but to get the full report, it must take me half an hour of digging. So I don't think our website is easy to use, and I'm just very surprised at this 75% figure. I'm also surprised that on page 5, we say that a 20% increase in website sessions to 10 million sessions. Well, that means there's 8 million sessions already. That is a strikingly high number. And I just wonder, with how much confidence we have in that figure. So presumably it means there's been 8 million visits to our website over the last year. That may be absolutely correct, but that is an extraordinary number if you divide it by the number of people going into hospital or the number of people in care homes or whatever. The final point is I do think this app, which of course Lewis has mentioned before, for people to be able to record their experiences is very important. I don't think this is very expensive to produce. I think it's the kind of thing which these days, 3 or 4 people could produce in 6 weeks at a very low cost. And but the question is, how do we get people to use the app? And it could be that every time somebody goes into hospital or a relative goes into hospital, they're told about the app, or every time a relative goes into a care home, they hear about the app. I don't know. But I think a simple way to convey information to us is very important. At the moment, it says that under 2,000 people a month are reporting their experiences to the CQC, which I don't think is a great number. And it also makes me slightly worried about the 8 million visitors, because how do you sort of square those? So I think digital is very critical for us, but getting a digital strategy in place, I think is, it's touched on this, but I think it's something we probably need, a deeper understanding of what is CQC's digital strategy. And again, it shouldn't be, we can't have endless items for the next board meeting, but maybe in a couple of board meetings' time, I think a better understanding, well, I would like a better understanding of our digital strategy, if that's possible.
Well, we can certainly bring that back. I think we do feel confident in the numbers. As Steve, I think, mentioned at the beginning, we had 1 million hits on our website on yesterday. That's the scale of what people use us for. It is at one level completely astonishing, but it is our reality. Now, that was an unusual day, but we don't just monitor that ourselves, and we have all sorts of ways of cross-checking that. And similarly on the 75%, and we have tried to validate that. looking overall at the digital strategy, it's an important thing for us to bring back. It's one of the areas that government is most bearing down on is digital spend. So we have as I think I might have mentioned this before, a £0 threshold for clearing any digital spend at all, whether that's on the website or an app or anything else. So that goes all the way through Department of Health and the Cabinet Office for any spend we wish. And part of the many, many bits of Chris's job, as well as support from Eileen and her colleagues, is negotiating that, which can be tricky at times.
So just out of interest, Paul, why is the government taking this stance towards digital spend?
Well, to some extent, I don't know if any of us is right to comment on that.
No, I don't think we can comment, but the strategy, on whether it's right or wrong, but the strategy of digital by default is to use as few systems as possible to enable the citizen to have an easy and seamless journey, which nobody would really disagree with. The difficulty in achieving that, when we've got many public bodies trying to do many different things, is actually that one solution does not necessarily fit everybody, and that's where we're constantly having robust discussions about, could we just step outside what you are permitting?
Look, I think we've had a good discussion on this, Paul. I think there's quite a few comments that need to be fed into this paper. I think there's an agreement about the broad direction of travel, but will you have a go at rehashing this paper?
Well, if the board's content, maybe I didn't hear it quite right, but I thought there was agreement to the strategy, but there were particular things that you wanted to add in. For example, Lewis's point. So if it's all right, I won't bring back the paper unless you want us to. We can certainly make the changes that have been proposed.
And recirculate it.
I'm very happy to recirculate it. Yeah.
Okay.
Is that all right?
Yeah, please.
Okay.
Okay.
I'm sorry, I don't want to. Very short point, but 10,000 hits on the website. I mean, I just the bleeding obvious, but an awful lot of those will be providers. So I just think that it's really important when we come back and talk about digital that we're clear about what we know about digital technology and the use of digital technology by the public, which is what this paper is about, as against by providers, which is another thing altogether. And equally, that 75% satisfaction rate, I mean, that might be a lot of providers who are finding what they want because they're spending the time to find their way through the site, but not necessarily the same for the public. So we need to know what the public think about our digital offer, which is different, and how they're using it, which will be different.
Just to be clear, the 75% is public, not providers. We track user journeys through the website, so we see absolutely where people go and what they use. So we saw yesterday, for example, how they tracked onto the website search, which told them what their GP practice rating was. And we also tracked a lot of movements from that to tell us about your care when the organisation was in Band 6. So we have absolutely that level of confidence in the data, which comes from Google Analytics directly, and confidence in the survey data as well. I'm happy to talk to non-execs about that in more detail.
All right, Chris, thank you very much. Next paper, this is the third time of asking, I think, the surveillance paper. I know that David Hogarth is desperate to contribute to this. So, David, if you promise to keep it to a couple of minutes, your contribution, you're very welcome to come and sit next to Steve there so that your comment can be done. But Andrew's going to kick it off.
Thank you very much. I mean, this is a topic that has generated a lot of interest, and I'm aware that many people, apparently including the BBC, are tuning in for this particular item today, so obviously facilitated by our own cameras. So what I just wanted to do was just to refresh the board's memory of why we are here, what it is that we're bringing to you, and what we need to do next. So you know that we raised the issue of the use of cameras in care in A Fresh Start when we published that in October last year. It was a subject of specific questions in the consultation that we carried out earlier this year, and we had roundtable discussion and several discussions at our external co-production group meetings, and indeed internally with colleagues across the organisation. We developed the information both for providers in terms of the things that we want them to look at, but also for the public, and have shared that with members of the external co-production group over the development of that. We've had some specific follow-up most recently from David himself, and also following on from the meeting that I had with the union GMB, because they had done some specific work with their members as a consequence of HC1 looking at the potential use of cameras, overt surveillance in their care homes, and that was very useful too. And as you've quite rightly said, David, we've had 2 previous discussions at the board. So where we've got to is 2 pieces of information that we would like to publish. The first is for providers, and this is setting out what we are expecting them to take into account when considering the use of either overt or covert surveillance. And the second is information for the public, responding to the anxiety that we know that members of the public may have either for themselves or for a loved one, and kind of responding to their reasonable expectation that the regulator will provide information to them to help them in that difficult situation. At the last meeting of this board, there were a number of comments that were raised by members of the board, and we've set out in the paper how we've sought to take into account the issues that you've raised. So in particular, have changed some of the focus of the public information document, and taking into account some of the comments that Robert made at the last meeting, really kind of amplifying some of the information for providers to make that as useful as we possibly can do. What I'm asking for from you today is hopefully agreement on the policy position that we've set out in both of these documents. There are some minor tweaks that I'd like to make just as a consequence of further comments coming in. So just reinforcing a couple of points around consultation with staff and trade unions, which came from the comments that we had from GMB, but also a couple of tweaks that David has himself suggested. The final thing that I'd like to say is that what I think that we've got to here, hopefully, is a position that sets out quite clearly what it is that we want to share in our information for providers and for the public. I think we've done a good job because it's our natural milieu is kind of providing information to providers and writing policy documents that do that. So I think we've hit the spot with the provider document. On the document for the public, I think that we've got the policy position in the right place. But what I would like to ask the board is your agreement for us to get some expert advice and support. Chris has gone out the room, but from Chris's team around turning that policy position as articulated, so the what, into a much better how in terms of a public information leaflet. Because I am aware that it sort of still reads a bit kind of, like a policy document. And I'm sure that there are ways that we can just phrase that as a public information leaflet, which will feel that much more accessible to members of the public wanting to use it. So I'm asking for your support for the content and your approval for us to move forward with publication on that basis.
Thank you. I'm looking at Lewis because you've had them. No, don't feel you need comment there, but I'm just anticipating that you might want to.
Well, I think this is progress, so that's the first thing to say. So the big change, I'm thinking mainly of the document that's for the public, actually. So the big change has been that it is now, that it's coming at this from the point of view that these are worried families, essentially, who want to know what to do next. And I think that shift has been really important, really helpful, and is definitely the right thing. I mean, I think you're right to comment on the style, because there are two aspects of the style that still need quite a bit of change, actually. One is this sense of it being a bit of an official document. It does read a bit like that. It certainly isn't very. It wouldn't be very accessible to most people. It does need a sort of a stylistic going over. I mean, to give you an example, even when it comes to define covert surveillance, it says, I mean, the very fact it has to define it. Surveillance is the monitoring of a place, person, group, or ongoing activity in order to gather information. I mean, a document for the public, none of that sort of thing should appear. So there are quite a few examples of that where you could even argue even the numbering of the paragraphs is not something the public are used to getting in things they read. So there's quite a. I don't want to play that down, because I think that is quite a major task. It probably needs entirely rewriting to get the style right. And then there's a second aspect of style, which is just it stopped being a little bit off-putting, which the previous version was, but it is still a little bit sort of coolly objective. And I think we've just got to maybe be a little bit more positive to people who are in this situation and trying to know where to turn. So I would say, for example, if you want to contact CQC, which I suppose is one of the main issues, if you contact CQC, we will always take your concerns seriously. We will give you a chance to say why you are worried. We'll give you information that tells you what surveillance can achieve and what it can't. And maybe also we'll help you decide what you are looking for in a technical sense. And we do have to think of what happens if people say, well, I'm going to do it. Where can I buy it? What are we going to say to that? Oh, I'm sorry, that's nothing to do with us. You have to look up your yellow pages or something. So I think that it is more than there's a big issue of style, but it is more than just style. There is a general sense of it being still not positive enough, and a sort of that positive tone would be is partly about reassurance. It's not yet reassuring enough to people who are stuck, who are worried but unsure what to do next. And with those two, quite extensive changes, but with those two changes, I think it will be ready to go.
Anna?
Thanks. So you've already picked up, and I completely agree with you that it needs a substantial kind of, not just plain English, but so we won't even talk about that. But I missed the earlier conversation at the board, so I came to this cold, if you like, read it for the first time, and I walked away with the impression that we think if I was reading it in this position, that actually there's an awful lot of risk around this, so I probably should go back and think again. That was the message it left me with, and I tried to work out why that was, and I think it's for a couple of reasons. I mean, it is partly the language that doesn't help, but I think it's for a couple of other rather practical reasons. One is, we tell them all the things that we seem to think they ought to do before they get to covert surveillance. So it's almost like you have to have done these things first. Talk to the provider, talk to us. It's thought about criminal cases, thought about safeguarding before you get to think about this. So it's kind of like a last step in a long process, which feels quite difficult. And the other thing is, we talk about all the risks but none of the benefits. So we acknowledge that people think there might be benefits, but we don't describe what any of the benefits might be. We don't actually explicitly say that if you bring us a tape, we'll look at it and we'll act on it either. I mean, in legal terms, we say we will accept all evidence, but we don't say specifically, and if you bring us a tape of covert surveillance, we will act on it. So there's something about being really clear about that. But the most important thing is we talk about all the risks and we don't describe any of the potential benefits. And I think that leaves you with a sense. And when we talk about the risks, we use the moral imperative. So we talk about should. So we say you should. And in other words, if you don't take account of this, you will have failed somehow in your kind of due diligence. So there's just something about the way that it's built and the way that we talk about it, which I think leaves a very particular taste in the mouth at the end of it, which is, oh gosh, this is all a bit too difficult. I didn't realise it was so difficult, so I won't do it, which is a very particular take on this. And I'm not sure it's where the board was when it had its previous conversation, which was more on the issue than one side or the other of the issue. So for what it's worth, that's what I thought when I read it. I've got one other slightly different point, which is in 2.3, we say we will use the information you share with us to help ensure that people receive high quality care. And I wish we could, but actually I think what we do is use the information that people share with us to try to ensure that people don't receive poor care. Not because I think promising that we help to ensure that people receive high quality care is a very big ask on the basis of issues that people are identifying at this level of safety or quality.
Camilla?
I think it is important that we explain to people that they need to think about privacy and they need to think about staff, because I think those are all really important. The one thing on the contractual and legal issues section, I mean, I just thought we slightly duck the issue of whether it's legal. The thing I would be most concerned about as an individual thinking about doing this myself is what is legal for me to do. And we say at the end, this does not constitute legal advice. You might want to take your own legal advice, but we don't quite say why. And we also say, will staff refuse to treat someone if there is an insistence that they are filmed doing so? It might be helpful to be clearer about whether that is legal for them. Would that be legal for a member of staff to refuse? I mean, it's just slightly vague, that section. And I think without us giving legal advice, we could do more to be clearer to people about what the legal issues are, particularly on that question about staff. I mean, I just don't know what the position is, but it's quite important to explain that, surely.
David, did you want to give your view?
Thank you very much. Well, I perhaps am in a minority here as being somebody who's actually considering putting in surveillance at the moment. I have to say that this paper doesn't encourage me. I have the feeling that, first of all, that you don't really understand where I'm coming from, and secondly, that you really don't want me to do it. And going back to Anna's point, this long thing, I would start the paper thinking it's going to be talking about covert surveillance, and it's talking, in fact, about all the things I should do before using covert surveillance. My position is really that I would use covert surveillance, first of all, probably to assure myself that I really had a concern, because so often you don't really know. And secondly, that if I was sure of that I would have the evidence to take it to you or the providers or so on. So in a way, I think there's a place for all this, but it's at the end what to do if you are worried as a result of the surveillance you've done. And then I think that the rest of it doesn't really meet... It tends to make me scared of doing it. For example, the section on privacy and dignity, it doesn't make the positive point that, in fact, if you've gone in a care home or even receiving home care, you've already sacrificed your privacy and dignity to the people who are giving it. How many more people are actually going to see this? And the section, I won't do them all, but the section on sharing, I'm worried about this getting back to the provider. It may be the provider I'm concerned about. I want to be able to give permission for it to go back. And the contractual and legal, the thing Camilla raised about in the contractual and legal, I'm horrified that the CQC should say that people might withdraw care without saying that you'd come down like a ton of bricks on any provider that allowed that to happen. In the past, you have rightly, I think, said that the proper place for people to bring their concerns is you, and I entirely agree with that, and not to the Daily Mail, not to the Panorama. Simply, and I would want to do that, and I don't feel I can do that because I don't really trust you to do anything about it. And yet, you are the people who can do. Take it to the Daily Mail, take it to Panorama, they can put it in, they can publicise it, but they can't do anything about it, and you can. and I wish that I could feel encouraged to do that. So that's what I have to say. I hope it was 2 minutes.
Well, thank you, and thanks for your contributions over the last 3 discussions that we've had. I mean, I think we're moving. I mean, I sort of feel we're 90% of the way there, actually. 50%. Oh. I thought from what you were saying, you felt that it was the style of the public information was your main concern, not the policy behind it.
And a positive tone. That's the other.
Yeah.
The positive.
Yeah.
And I think that's where style and public sector documents, it's more than style, because we are hesitant and say, well, there's 73 things you've got to think about, and we think we're being helpful when we say there's 73 things you've got to think about, whereas actually that's just saying, I really don't think this is a good idea. So what we think is balanced from where we sit comes out as unbalanced because of how it's read. And so it is style, but it's then actually having it read by someone who we think we're helping, who then says, you're trying to tell me not to do this. And that's because of who we are and how we write things and how we think about things. And so I don't think this is a lot of work to do where we've got to get to. It just needs someone helping us to write it that will get to the outcome that we want to get to, and probably can't be us. Which, something like that, an organisation that is used to helping people and using the law, but it's not a public sector body that feels we're going to be sued if we say this. If anyone does anything with anything we suggest they do, we're worried about them suing it.
Thanks, Paul. Andrea?
I think this gets to the heart of kind of why are we trying to do this and what is it that we are trying to do. And we had this conversation over 3 meetings. We've seen a fresh start a year ago. We saw the consultation document. The drafts have been shared with board members before this meeting. I think that we have, collectively agreed that the public have a right to expect us to provide some information to them on this very tricky topic. I think some of the points that David has made in terms of the just reinforcing the kind of, you might be wanting to do this to check your suspicions are justified so that you can kind of raise that and use that as evidence. Absolutely fine that we can take that into account. And clearly, as in any other complaints or issues that are raised by people who are using services or their families, we would come down like a ton of bricks on people who kind of then inappropriately responded in the way that they provided care. So we can be clear about that, and we also can be clear that if we do get information from the public, we will do something about it. And I think that those are all kind of quite helpful strengthenings of what we've written. I think that the point about the style, I'd already kind of acknowledged, and I think it is somebody taking this and sort of turning it into something that is useful for people to use. But the final point is we are a public sector body. We are the regulator, and so we do have to be mindful, and that's the reason why Rebecca sits at the table when we have our board meetings. We do have to be mindful of how it is that people will use our information and how that's judged. And although we have people reading this and saying, well, this sounds like you're saying that we shouldn't be doing it, we have other people reading it and having front page headlines that say this is a green light for spying on care homes. So people interpret what we're writing in all sorts of different ways. So we do have to be careful, and I think it's appropriate for us to be careful. But I honestly don't think that we're 50% away from this. I think we are an awful lot closer. I think we can get some expert assistance in turning this into something that can be useful and can be consistent with our role and responsibility as the regulator of health and social care. and can dovetail with the information that we've not talked about, but I think is equally important, is the information that we're sharing for providers in terms of what considerations we're expecting them to take into account, because we know that providers are proactively looking at this at the moment, and our inspectors will be out looking at services where either cameras are in situ or where the provider is thinking about doing it, and they will be asked for advice at that stage as well. So that would be kind of my response to the comments.
So on the issue, remove the moral imperatives, introduce the word help, clear up the vagueness around legal, and get somebody that's not us to write it. Okay, that's what we'll do. And that means it won't go out this side of Christmas. That means there are a number of organisations I can think of. Paul, you mentioned one. There's a number that we could look to that come at this more from a consumer rights point. I would just want to emphasise that we're not a consumer rights organisation, and therefore we've got to hold the line on what our position is on this. But if this is hitting the wrong bell, we can't bring this back again. So we've got to land this point and actually do it in a way about style. So we're going to take really seriously this issue. The content is settled apart from on the message, vagueness, remove moral imperatives, introduce the word help. I urge you make a point at this. Yeah, well, help is, I think, is using those kind of language in that. So but substantially, this is what we're going with. The issue is about how we present it, and we'll not try and do the final draft without getting some help from organisations that I think have a track record about this. So if we take that away on that basis, David, and try and settle that again, rather than reopen the content debate. And I include David's comments in this as well about just thinking about those. I've played back to some of Anna's language and Lewis's language, but we'll play back your language as well, David.
I don't think you should take it as a miss that this is the third time. This is a difficult issue. I think the nuances are important in this. So it's not. Don't take this as a reflection on the quality of the paper. I mean, I think it's important that we have this sort of iteration. Okay, then we'll move on.
Should we get someone else to publish it and own it?
Well,
do you see what I mean? Because we have to be, there are certain sort of things that we have to say and do. I just wondered if we could approach someone else. I don't know. I'm not quite sure. Consumer rights. I don't know. But we'd obviously be linked into it. But it would actually sit with someone else. Do you see what I mean? It kind of.
So let's take it away. This is our shout. We've got to give guidance. We set the standards about what goes on in care homes, and we're supposed to be the guardian of those. So I do think we've got to have our imprint on it. One of the things that is going through my mind, where you get the plain English test, you'll often have the plain English logo at the bottom of a document that's branded for the organisation. And I just wonder, this might be one of the ones where somebody might be prepared to help us with this and put their brand on the bottom of it, and then, in a sense, do it in the style that they're doing. I don't want to mention organisations publicly. Let's take it away. We'll end up in a procurement issue as sure as eggs are eggs. So let's just think about how we can do this and what the settlement might be, where we can. Paul's point is a really good one about there are some folk, and this is their business to write this kind of document. So let's go and have a conversation with them about how we might do that and settle the style issue in a way that is more positive, more helpful, is less as if we're grudgingly doing this and not meaning it. Anna's phrase, on the issue, not either side of it, I think is a really helpful phrase to use about where we need to be. And that's what we've tried to do from the last one. Clearly, we've not landed it. It's not a criticism, David, but I think we do need to settle it. There's a whole bunch of people out there who want us to do this because we've been having a conversation with them for, 9 months now, I think this has been going on. So we do need to settle it.
Michael, if you wanted to have the last word, you can.
David, I'm slightly anxious that we're forgetting the guidance on providers who presumably are waiting for guidance. And personally, I thought that the provider paper was very useful, and that perhaps the language issue isn't quite so vital for that. And is there any reason why both these have to come out at the same time? Could we not be seen, with all due respect to ourselves, make some progress on this in relation to at least that document?
Andrew, that's possible, presumably.
absolutely. I mean, that's the reason why the two are separate. And I do think that we're kind of much more used to writing the kind of document that we've written for providers than we are in terms of writing the document that we've written for the public. So I think if the board are happy with that, then we can progress with the publication of that information document.
I was going to make a point about the provider paper too, which is, I think the point in the public paper, will staff refuse to treat somebody? I think we should say in the provider paper, well, assuming that we're allowed to, that if a resident or relatives have installed some form of covert surveillance, it's because they're worried about the care they're getting. And this is I don't know if we can say it, a totally legitimate thing to do. And we don't actually give providers any guidance on what to do if one of the residents or relatives does install covert surveillance. But I think in that way we can take a more positive stance if we feel we can say that this is because a relative or resident is worried about their care, and it is absolutely, I don't know if we can go, I'm not trying to draft this on the spot, but it would be completely illegal if you withdrew care or restricted care if you found that somebody was using covert surveillance. I think that's a very important part of the advice we should be giving to providers. And it could position us, on the patient side, which I think is the point the colleagues are making, because that's, resident side or user side, because that's the point, that's the place we want to be.
I think that's a really helpful comment, Michael. It's not covered in the paper. I think that we probably could, but I would certainly want to take Rebecca's team's advice as to precisely what we should say. But we absolutely need to be clear that we would not, as I said, as in any other complaint or issue raised by somebody using a service or their family or their carer, they should not be experiencing a deterioration in their level of care and support as a consequence. And also just to remember, although this kind of has been led out between the adult social care policy and operations side. This is a paper that is for all of the sectors, and we've deliberately kind of written it in that way. So it impacts on health settings as well.
Thanks very much, Michael. Thank you. Eileen, Declaration of Interest Policy.
Okay, thank you very much, David. Hopefully this paper will in large part speak for itself, but I don't want to diminish the importance that we attach to it, because having in place an effective declaration of interest and resolution of conflicts policy does play to the integrity and the innate professionalism of the way that we work and execute our purpose. So what you have set out for you, it represents something that has been through an internal audit process twice now, and the second time has been altogether a more positive one. So there's been lots of learning. It went through ACGC, our audit committee function, last month, and Paul Rue led discussions there, which led to some amendments. And I think the three key pillars upon which this is built is the recognition that it is important to get this right, and it plays to the integrity piece. That what we're doing is appropriate for an organisation executing the work that we do, and that it is proportionate, and that's where we had some discussion and debate, but have accepted the ACGC recommendation about what is held to be proportionate there. So what we have set out are 3 lines, if you like, of declaration and points where we would be seeking to build the confidence and awareness of all of our staff around how you identify a potential conflict, and then we manage that through successfully. That is at the point of appointment, and thereafter annually you will be asked to make a declaration of any interests or potential conflicts that you have. if you're in an inspection area, you will be asked across the portfolio of work you do to, on a quarterly basis, review that portfolio and to think about any conflicts that may arise during that quarter. And then as you undertake each inspection, you're also asked to work with your manager by way of a very simple email to set out that you have no conflict around that particular inspection. So it is a 3 lines of defence approach, if you like, but we do hold it, as I say, to play to the fact that it's important, it is appropriate, and it is proportionate. We've discussed and debated this extensively, and we are not going to just put it out and expect staff to comply with it. There is going to be a process of actually educating our staff and bringing them with us as to why this is important, and having regular reminders and updates about that. So, as I say, it plays out into that space. We're going to be using our learning management system to actually have a very simple way of making a declaration. And I think this moves us on considerably. And in parallel, our flexible workforce that we talk about quite often, our specialist associates and our experts by experience, who actually do make regular declarations to us at the point of an assignment, we're going to be tightening and scrutinising that still further with the assistance of internal audit. So bringing this together and ensuring that we do have a proper oversight and a very mindful and thoughtful approach to what a conflict of interest might look like in the context of our work. So happy to take any questions, but as I say, it's been through ACGC and reviewed extensively there.
Any questions for Eileen on that? Anna?
So no, it's just a comment. It says in 2 places that this policy will apply to Healthwatch England staff, and I just want to say that we have a policy which already applies to all of Healthwatch England staff, because conflicts of interest is hugely important to Healthwatch nationally and locally. And while the principles of the approach that are adopted at the CQC must absolutely apply to us, it's quite often the case that the specifics are slightly different for us. In fact, we're very quite fearsome about conflicts in Healthwatch because of our particular position in terms of kind of commenting on other organisations. There's something about being whiter than white, which is kind of pretty critical to Healthwatch. So I just want to put up that marker and say I think we need to have a conversation about this, the way that it applies to Healthwatch.
You pick that up outside the meeting, yeah, thanks. Okay, can we agree there? Yep, thank you. Did you want an update from Healthwatch? Or was that just for noting? Just for noting. Any questions from the floor? Yeah.
Thank you, Chairman. Thank you, Chairman. A question about pharmacies, if I may. I understand that the Sir Bruce Keogh is advising members of the public that they should, in many cases, take medical advice from community pharmacies as opposed to their GPs. And community pharmacies already deliver a number of medical services, injections, vaccinations, and so forth. Is there any intention to inspect community pharmacies? And then on the other side of the coin, the hospital pharmacies, because patients do quite often find they have difficult experiences with hospital pharmacies, particularly in terms of waiting. And whereas in general practice, prescriptions are often paperless, hospitals still seem to have a lot of paper.
Thanks.
For you.
Ooh, there's an echo. I'll do a duet with Mike if that's okay. So I look after the pharmacy team here in CQC, but Mike can answer for the hospital side because he uses our teams as well. And the community, I, as a GP, I strongly support the use of pharmacists to take the load off general medical practice. And as Chief Inspector of General Practice, when I go around and see practices, when I read the reports, that re-emphasises my my view that pharmacists have a really important role to make. Their training has increased in time and in clinical experience over the years. The only thing I would take issue with your question is that it's not medical, it's clinical. They're subtly different. They have their own regulator. So we do not have any plans at the moment, because that's not within our remit as a regulator, to go and look at community pharmacies. However, I do think as more care, perhaps for long-term conditions, moves to community pharmacies, we will be doing more work with the pharmacist regulator jointly, because there is going to be a potential gap between the general medical practice and the pharmacy. Where care works best, it's when those gaps are joined together, the organisations work seamlessly, and the common issue, not just for pharmacies and general practice, but for integration generally, is that we desperately need shared clinical records across medicine between hospitals and general practice. But in Southwark and places like that, they're using some joint records with some pharmacies. It's working really, really well. So it's on my agenda. And as the new year comes, I think we'll start to do more work talking to them. But for hospitals, that's Mike.
Thank you, Steve. So in terms of hospitals, pharmacy is not per se one of the 8 core services we look at, but it does come into at least 2 of our core services, one being outpatients and the other being inpatient care, particularly when we're looking at the discharge of patients. And I don't know how many reports we've commented on it, but quite a lot of comments we've made about patients who are waiting in the discharge lounge. And why are they waiting there? The commonest cause of that is that they're waiting for medicines to be dispensed. So we are reporting on that. And of course, we do also report more generally on medicines management in all of our core services. And this is something that I'm working with my Deputy Chief Inspectors and actually somebody from Steve's Directorate who heads up the medicines management function for CQC to see if we can strengthen that further as well.
2 questions. Or was that your first?
It was a single question, if Chairman would permit. The other question related to what happens next, where a patient has incurred serious harm, possibly nearly died, or maybe actually died. As the Care Act has created this new criminal offence, how can the patient or their relatives enter the pathway of a criminal prosecution? This is against a landscape where it would appear that many cases of abuse and sexual assault have not been pursued through criminal prosecution.
Yeah, I think this is the offence of willful neglect that's coming in, that particular one. So that is not a CQC enforceable piece. As you rightly say, it's criminal through the police and the CPS. So I guess the 2 parts to the answer. A member of the public who's concerned, that's happened to or happened to a loved one, should directly contact the police. As with other criminal matters or those criminal matters. But just as we were having the earlier conversation about all concerns, there needs to be a consistent routine, whether it's a whistleblowing or a safeguarding or a concern being raised. We would also encourage them to talk to us so that we can bring that into our regulatory activities, not for the pursuit of that individual offence or recourse or remedy, but so that we can make the appropriate regulatory judgment, if that makes sense. And do so in the normal ways through our phone lines or other contact methods.
Good. Thanks very much. Thank you. Should we break for lunch? Thank you.